Welcome back, everyone. Okay, guys, welcome back. We're going to get it started. So I know people are having internet issues, and I know I was having the same thing from home. So we record it, so that's okay. You know, if you have a problem with that, I know people will text me, which I appreciate, but don't worry about that too much. You can listen to the recording later. So good job on the simulation. So you guys finished your second face-to-face simulation. It looks like you guys have one more simulation with PEDS. So that starts on Monday. So that will be good also. There was a couple things. I know every group is different. So Some of the groups got to do CPR. Some of them, we talked about the PEDS cart. So there were kind of different things that you guys will learn, and you'll see some of that again. Hopefully they will have that lab. Also, some students were actually asking about face-to-face. So hopefully next semester you guys will get time if you want to practice a certain skill or a certain thing where you can work with some of the faculty to do those things that you really want to get practice on. And more than likely, or I know, pretty sure that you guys are going to be face-to-face in class, which will be nice. So we'll be back in the classroom. I don't know what that's going to look like. Hopefully no masks. And it sounds like the state of Texas is going to open up their COVID vaccine. When I was talking to Stephanie, January 29th of this month. So then everyone over the age of 16 can get the vaccine. So there won't be any restrictions. So hopefully we'll all get it. We're still waiting on the university. I've been asking Professor Lockhart about university, getting the vaccine, because the plan was whoever wanted it, they were going to have that available, but they have ordered it and they still haven't gotten theirs yet. And it's interesting because whatever they get, you just don't know what you're going to get when you get it. So you might get Moderna, you might get Pfizer, you might get Johnson & Johnson. So and I think AstraZeneca now is waiting to get FDA approval. So if it's going to be 1 shot, 2 shot, it depends on what they have. So as soon as we get stuff at the clinic here on campus, then I'll let you guys know about that. Okay. All right. All right. So calendar wise, if we look at the calendar, so we have today, and then we have, the Christmas break, or the Christmas break. I'm back at Christmas now, you guys. The Easter break starts Wednesday, at 10 o'clock for a holiday. Okay. So you have Thursday, Friday, Saturday, Sunday. So we miss the next class of Family Health 2. So what I will do is, if I don't get through everything today for immunity cancer, I'll do another. I'm for sure going to do another lecture for you guys. And I'll probably do the PowerPoint with the voice. I don't know. We'll see which one I want to do. And I'll put that on there for you. Okay. So since we don't have class next Thursday because of the break, and then after that, we'll just have 2 more classes on the 8th and the 15th for Family Health 2. And then you'll have your 3rd exam for Family Health 3 on that day, the 22nd, which is at 7 o'clock. That one's at 7. We couldn't get the room till 7. And then the Sigma induction ceremony for the folks that want to do that. There is that week, we have virtual sims those last 2 weeks on the 12th of April and then the 19th of April. So there is a group going on that Friday. So if you want to be part of the induction and you're in that group on the 23rd, I can move you to another day. There were a couple people that might need to do that, so that's no problem for that. But that last exam will be on the 22nd, and then you guys will have your final on the following 29th. So just looking at the calendar, it's coming up really fast. So basically after this, we only have 2 more classes. So so whatever content, instead of speeding through it really fast, and I'll just make a recording for you guys. Okay. And that will be extra. All right. I want to see if they're okay. So for today, the things that I want to highlight, I've been looking and kind of trying to trim down some chapters. So for today, the main focus for immune cancer will be chapter 35, chapter 36, and then chapter 15. It's different on the calendar. I think we had 37 and 38, and then the main stuff, but the main cancer information that I want you to know is in chapter 15. Okay, so 35, 36, and 15 are the ones we're going to go through. And then I have the PowerPoint lecture that goes with the book, and then I have another, like with we're going to do assessment of the immune function, and there's 2 shorter presentations because I like pictures and I want to show you things a little easier to see in diagrams. So I'm going to give one, and then we're going to look at the book one that follows up, because the book one just doesn't have a lot of pictures or kind of things to help study. So that's what I'm going to do today. And we've been doing that in the past, but that's what we're going to do today. Okay. So you should be able to see all of them. So we're going to start with this assessment of immune function for the first one. Does anybody have any questions? And yes, in that, did you guys get to email Stephanie Sullivan for that resume stuff. So we'll see how many good. So we'll see how many. And then I haven't been able to put the Dropbox in because when I tried to put it in, I have to go into another platform here to put it in because it's given me a hard time with that.
I think I must have missed that about the
Oh,
resume.
yes. And I'll show you. So it's I'll show you. I can tell you about that, Kristen, after.
Okay.
And if you can watch like the beginning of that, you can see it too. But I can tell you about it. All right, guys. So let's talk about immunity. So what is our immune system? What are we doing with that immunity? For our immune system, what are we trying to do?
Protect our body. It's protecting our body.
Exactly. Protecting your body, fighting off a disease. So just to refresh that, immunity, body's ability to resist disease. And the immune responses, there's 3 different functions that we do, right? We defend against those microorganisms. It provides us with the homeostasis by digesting and removing those damaged cellular substances when we have some type of injury or inflammation. And then it does surveillance by recognizing and destroying it, right? All right. So you're going to have 2 types of immunity. You're going to have an innate immunity that's present at birth. That's what, and when we talk about our innate immunity, and it's the first line of defense against a virus or injury or whatever has happened to us. And then we have an acquired, and it's a developed immunity, and it can fall into 2 categories, either active or passive. Okay, so if we look at the first one, our innate, all right, hold on one second, you guys, I want to see. Okay, with that, if we'll look at we're going to go back to the innate in a minute here. If we look at the one that we acquire, or the different, here, I'll go back, the acquired or the developed one, you're going to see it breaks off into different categories. And this will come up in PEDS when you're talking about that. Have you talked about it in PEDS yet? I don't think you have. With vaccines or anything. So the first one, no, you guys don't
We
remember?
have heard about it in the past, though.
Okay, yes, at other classes.
Like
but
back in A&P and stuff like that.
Right. So again, to just refresh, you have your natural, which is the active. So we have a disease, like we get chicken pox and measles and mumps. What happens now is a lot of times we give the vaccine for that, right? For measles, chicken pox, the varicella is chicken pox, and then the measles, mumps, and rubella, MMR, is one that we give a younger children now. So instead of that having that disease naturally, like when some older people had caught chickenpox and gotten it naturally and had the immunity against it, now we're giving an acquired vaccine. We're giving an immunization against that. So instead of those children's getting chickenpox and measles and mumps that have happened in the past, now they're getting an active acquired one artificially through immunizations with that antigen. Okay. And then if we look at the natural passive, that's when it passes over to us from like the mother to the baby in utero. So a transplacental passage or colostrum in the breast milk that happens to mother to child is a natural passive one where they're acquiring it from their mother. And then if we look at an acquired passive, it is injection of antibodies from an immune human or animal, which happens like you'll hear immune globulin, or we'll get an injection from it, but that doesn't stick around. It'll just last for that period of time to fight off whatever is happening at the time. And we have to get revaccinated for that every year when that happens in a passive. Okay. All right. So we have that antigen. Remember, that's the substance that elicits an immune response by stimulating the production for that to happen. So antigens are those viruses, that disease, whatever we have possibly caught or is happening to us. And then the antibodies are those substances produced by B lymphocytes, which neutralize or destroy antigens. And we're going to go into B cells and T cells. Okay. All right. So if we look at this, you have a picture like this in your chapter, but it's a little complicated. So I like to show you guys this picture. So what happens is we have this virus, right? And it comes along and it enters into the body cells, okay? Then we have where it it invades through the skin or other portal, right? And makes its ways, and then it replicates itself. The macrophage over here, then we have those macrophages that recognize the antigen on the surface of the virus and digest the virus. So it takes it in, and you guys see where it can take it and it just starts destroying it and displays the pieces of the antigen on the surface. Okay, so it's got those on, and then it's breaking out and it's going. Then we have the release of those interleukin or tumor necrosis factors, which tell us to start developing these T cells and these B cells to mount an attack against it. So the cytokines are that substance, we call them cytokines, that release to say, hey, there's an invader in here and we need to come and take care of this, okay? So those T cells, there's like 3 different types of T cells that will help with killing that virus that's come about. All right, so you can see how there's these T helper cells, these natural killer cells, and then these T cytotoxic cells. So they're showing you in different colors how these activate and start killing that virus within that cell, okay? Then you have the B cells that are going to produce those antibodies and recognize and again attach to that virus that is still out there and to help get rid of those viruses also, but then has the memory of that virus. So when it comes back again, we will have the memory of those antibodies that can kill that virus when it comes back for the second time. So the memory doesn't produce until after we get attacked that first time by it, right? With that different organism. Okay, so with our organs of immunity, we have primary and peripheral we'll talk about here. So I've included the picture. So if we go back and we'll look at this in a minute, our central or primary lymphoid organs are your thymus gland and your bone marrow. Okay, so those are what we consider the central. So what happens with the thymus, it's bigger when you're a child and it starts shrinking as you get older. Does anybody know where the thymus, do you guys remember where the thymus gland is? Now, what's the gland that everyone gets it confused with, the thymus? That's in your throat area.
The thyroid.
Yeah, everyone gets confused with the thyroid and the thymus, and it's easy to do, right? So it's up in that chest area, in that mediastinum. It goes around along your bronchioles and in that same area, and it shrinks with age, and it's involved in the differentiation and maturation of the T lymphocytes or the T cells. And we'll talk about those more when we talk about HIV. All right. And then we know that the bone marrow produces those red blood cells, those white blood cells, the platelets, and then the B cells turn into plasma cells, which can produce those antibodies. All right. The way I like to remember this is thymus gland T cells, right? And bone marrow B cells. So it kind of gives an easy way to remember where those start from. All right. So the peripheral lymphoids or lymphoid organs are the ones that we talk about, that you kind of come to mind when you guys think of our lymph system. So those lymph nodes. Now, should you be able to feel your lymph nodes? When you guys are doing an assessment and you're feeling up around, what do you guys think? Should you be able to feel your lymph nodes normally? No, right? Yeah, usually not. When you're feeling for them, you're not going to feel for them. If you start feeling the lymph nodes and they're like, oh, hey, feel here. You'll have patients that'll say, oh, hey, feel it here. So if we feel and we can feel those lymph nodes and they're kind of squishy, but we can feel them kind of protruding, especially down around our jawline is a big place, or up, we know we feel up in the shoulder area. What are we thinking when we feel that we can actually feel them on a patient?
An infection.
Yeah, that they're fighting an infection. So now if they're squishy and they feel pretty soft, is that a good sign? Would you guys think? Or is that, or if we start feeling a hard lymph node, then what do you think?
I
What is,
think the heart is worse.
yeah, the heart is worse. So when we start feeling something that's hard, like a lymph node that's hard, then we start thinking about cancer, something's going on, or that is causing that. Because if you are sick and fighting infection, sinus infection, flu, whatever, a lot of times you'll feel where you can feel them, but they're soft and they, you know, they indent pretty easy. But when you start feeling something harder, that's when we start thinking, oh, okay, you know, that's not, we're just going to have to keep an eye on it and see. And that person who has a harder one, we're going to have to go test. We're going to have to run some tests and try to figure out what's going on. So we have those lymph nodes. We talked about tonsils when we talked about our ear, nose, throat, when we were looking, that we could see that those get enlarged. You can have pustules on them sometimes. Then we have our spleen, and then the lymph tissue is associated with our gut, our genitals, bronchi, and skin. So if we go back, and you guys have a good picture in your book, similar to this, where you know that our lymph nodes are kind of all over our body. They're we have them in our GI and our gut. So what's in the GI that fights off if something gets into our stomach that has to do with immunity? What kind of natural things in our stomach to help fight off some kind of virus, or some, if we eat something that's bad, what do we have in our stomach that'll fight that off?
You talking about the acid?
Mm-hmm, the acid. So the HCl, the acid that's in our stomach. We have that first barrier that is, if we look at here, we have skin, right, as our first line barrier. And then we have that stomach acid that we can have. And let's see. So we have those things. I want to read off if there's a, so we, what else would you, what else?
Hair patches? P-E-Y?
Hair patches, is that what we said?
Yes.
Yes. Mm-hmm. Hair, or even the cilia in our nose, right? Would be also considered that first line of defense that everybody has. So that property that everyone has. Good. And then we have our skin, genitalia, like those, the fluid and the hair patches, and then the bronchi, which we have those Pac-Man or macrophages that will eat in the bronchi that will take care of some types of infections that are coming about. Okay. All right. So different factors are going to affect our the immune functioning. So you're going to have that decrease in that physical barrier. So the big thing, like if we're taking care of a patient and we don't have those gloves, if we have a cut in our hand, we're going to be worried about that, right? So those first physical barrier, those things that can break down with physically, our age is going to affect that. We talked about when you have an older patient who is especially women come in with UTIs, their white count might not be high because of their age, because they don't have that same immune property that's going to fight it off like they were when they were younger then, okay? Gender can come into play, nutritional status, if we're not getting the right nutrients to help with that. Stressors in our life can cause that, or even other physical ailments, like other physical diseases, like a secondary disease, like if you had diabetes or something that would not allow our immune system to work as well as it could, or any kind of immune genetic disability that you have. And then we have therapeutic modalities that we've used to help with that. Does anybody know any kind of modalities that you'll see people use to help with their immunity? Has anyone heard of any that can help? Like massage, meditation, written emotional expression. They tag that with HIV, group drumming, music therapy, and then another one is essential oils is a big one that you'll hear lots of people using now to help with that immune property. Okay.
Professor Hall,
yes.
I didn't know when I was doing the prep use, that was one of the answers. One of the answers to what would improve your immunity would be family support, and I had never thought of that, but that was one of them. So yeah, I guess what I'm saying is the more the more you are together physically and mentally, then that improves your immunity.
Correct. Yes. Good. Yes. So yeah, so they don't have that stressors. They have good support system. That's why when we always go to mental health, like when you guys are doing docket care, we'll always ask about, okay, what kind of mental or family support does the patient have? Because that makes a big difference in how they're able to handle the disease that they have or what they've come in with. Because when they're kind of alone and living alone, they don't have anybody in town, everybody's out of town, it can make a big difference, and you can kind of see the picture with them. So yeah, good. All right, so we have 5 classes of immune globulins that you guys will hear about. So with this response is our humoral immunity. I'm going to show you guys another chart here when we go back there. But we have 5, there are 5 different immunoglobulins that you will see. And if you look at humor, what's humoral mean? What is that? What is humoral? It's a Greek word. What does it stand for? Does anybody know? It's close. You think that was good. It actually stands for fluid. So that's what's floating around in that fluid to help fight off these different viruses that come or whatever is causing us problems. So immunoglobulins are antibodies. So you've got these 5 different classes, and you need to know about these 5 different classes. So the IgG, that is the largest component of the total immunoglobulins, meaning the most of them are out there. It's found in plasma and interstitial tissue or fluid. The only Ig to cross the placenta is IgG, and it provides newborn with that passive acquired immunity. Okay, so that's IgG. So this is one, IgG is one you'll hear when they're fighting different diseases. You might hear patients who actually receive IgG to treat different conditions. A lot of times you'll hear neurologic conditions where people will get these antibodies to help them fight up, and they've had a lot of success in the area of IgG treatments. Has anyone heard of that before with any diseases that they've worked with? No. Okay, good. Just curious if anyone's seen those before. Okay, so that's the first one. The second one is IgA, which is found in body secretions. So saliva, tears, breast milk, and colostrum. And it lines the mucous membranes, okay? So IgA is the second one. Yes. We're constantly sending them to the infusion department, and it works for various treatments. Yes. So what have you seen at Avery work for? What different, is it mostly neurologic stuff you've seen? And how, is it come like a blood bag? It's from what I can tell, it's like they're giving it similar to, how many cc's? Is it 250? How are you seeing it? I'm going to use Avery just because she's the expert on this because she actually works right now. I'll see. To the infusion department, I think if anything, ours is injection syringe. Okay. The ones I've heard about people are getting is they'll get like a 2-hour infusion of IgG for this. But it sounds like they're giving syringe injections. So that's interesting, Avery, because I've seen kind of 2 different things. All right. So the IgM is the largest of the immune globulin, and it's found in plasma. And it's responsible for the primary immune response. So it's the first one to show up, and I'm going to show you guys a diagram of that. And it forms antibodies to the ABO blood antigens. So that's going to be, the IgM is going to be that one that if we give the wrong type of blood, that's the one that's going to show up to help us with that, okay? IgD is found in plasma, again, present on the lymphocyte surface, and assists in the differentiation of B lymphocytes. And we're going to look at that one. And then IgE is found in plasma, interstitial fluid, and it causes symptoms of an allergic reaction. So you guys want to know, you need to learn what these 5 and what they are working towards. All right. So IgE, eosinophils, we know that will tell us if it's an allergic reaction. So that's an easy way to remember that one, or try to remember that. totally easy, but it helps you remember that, okay? All right, and we'll look a little more at those as we go. All right, so what we said is when an individual is exposed the second time, the response is faster, 1 to 3 days, and it can last longer. So it's the main product of the secondary response is the IgG rather than the IgM, and memory cells account for a more rapid production of that IgG, okay? So here we go. Here's similar to what it reminds me of the troponin, right? Myoglobin, that how we did those labs. You're going to have, it's the first exposure. So what kind of exposure have you guys seen with something that like a sting, or, you know, what's some other things that people are allergic to that we can have some kind of response towards? What have you guys been putting in DocuCare, kind of right at the beginning of the DocuCare, that would create, that would elicit it? So yeah, medications like a penicillin. So that first time that you receive penicillin, the patient usually never had, they don't have any problems, right? Because they've never had it before. If they've never had penicillin before, then they're not going to have an allergic response the first time. Or if they've had a bee sting, they're not going to have a response the first time. It's going to be the second time, okay, that they're going to have it. So their first exposure happens, and then it's delayed where we have this IgM, that response. But that second response is when we're going to get that spike of that IgG that's going to cause us a problem, and we're going to have possible problems with an allergic reaction, okay? And it's Fox is like, okay, let's go. Multiple sclerosis. Okay, so she was showing, I was looking at Avery, she was saying multiple sclerosis they're using it for, a neurologic. They had amputations and they had phantom nerve issues. Oh, wow, okay. And sorry, I have some major, no, you're right. Yes, that's right, that's programmer. No, you're good, Avery, you're good. All right, so it's interesting to kind of see how people are using it. All right, so now if we look at, so that's our plasma, that's what's happening when we first have that reaction in the humoral or the fluid part. And then we also have a cell-mediated immunity. So it's against the pathogen, immunity against the pathogens that survive inside the cell, the viruses, bacteria. Sometimes it can be in fungal infections. If we have put in a kidney transplant or a heart transplant, any kind of transplant, the cell part of the immunity is the one that's going to reject that transplanted tissue. All right, and then contact hypersensitivity reactions will happen with that cell part of the immune response, and then tumor immunity. All right, so there's different 4 categories of disorders that you'll see, all right, for people when they have these different disorders. So the first one is going to be hypersensitivity, okay? And that is an exaggerated or an inappropriate immune response, all right? The autoimmunity, what's an autoimmunity? What's happening with that? What type of cells is it attacking in an autoimmunity, just from the word? Do you guys remember that?
The body's self.
Its own, right? So that gives away what's happening there. So it attacks on its own, has host cells, it doesn't recognize it. And then the immunodeficiency, right, is that deficiency of one or more immune components. And then that last one, that gammopathy, is that abnormal production of the antibodies, okay? All right, so let's look at those. So with hypersensitivity, a lot of time it can be an allergy. We have the allergen, the antigen, which is that allergen, and then we have the responses from both that humoral or cellular component that's happening. All right, so if you think about this with disorders, you want to think of the nursing process, that assessment, analysis, planning, implementation, and evaluation with that. All right, so there's 4 different types of these. So type 1 is an anaphylaxis. All right, so you must have, and I like to put our memory sheets. So if you guys have those memory books, those will be in there. So an anaphylaxis is a type of type 1. We have to have that first previous exposure. Our IgE antibodies are going to show up for that. a histamine release is going to happen, and it can lead to an anaphylactic shock. So if we look here, we're looking at different causes. We can have that bee sting, that medication reaction, even a food allergy. All right. And then we're going to start seeing that rapid onset of sweating, feeling really apprehensive. They start getting that tight throat. Bronchospasms can happen. They have that initially tingling of their face, weakness, and then that loss of consciousness. And our big thing that we give in the hospital is that iodine that can cause, we want to find out if they're allergic to iodine, especially if we're doing something in radiology. All right.
Professor
So,
Hall,
yes.
question?
Yeah.
On hypersensitivity. So I wanted to make sure I understood.
Mm-hmm.
You were saying something about that first initial reaction, people may not have. Are you saying that they will not, or they may not?
They will not. They will not have it until they're exposed that second time. They might have a slight that you saw reaction, but it's not enough that it's going to say, okay, I'm allergic to this.
Okay, so there could be possibly a reaction.
Yes.
The only reason why, because I was asking is because on a bee sting, I've never been stung by a bee, but the first time I got stung, I did have a bad reaction.
Okay.
And the first time I ate fish,
Mm-hmm.
I had a bad reaction.
Okay. So
it was enough to where it was enough to let me know that there was something wrong.
Mm-hmm.
Nobody else around me acted upon it. And
Okay.
it was as I kept being introduced, then the problem was getting worse and worse and worse.
So you might have had that IgM reaction at first, which is that slight one, but then the second time is when you have that really full-blown reaction, if you're going to have a bad reaction to it, where it would possibly go into that anaphylaxis.
Okay. All right.
All right.
Thank you.
Good question. That's a good question. All right. So treatment with this. So if it's a local reaction, we're going to do that antihistamine with an IM or a PO. So you know that people, what are different things that we take for PO or IM for a local reaction? What do people know to have on hand?
Benadryl.
Mm-hmm. Benadryl. So we know that's when we can use a big one that people have with them, or they know to take that if it's something like that starting, right? So for the local reaction, and then we'll also sometimes give a prednisone dose pack for that. Okay, Zyrtec, yeah, that's another one, Taylor, you can use. Mm-hmm. And then with a systemic, which is that all over body one, when I showed you guys in the cart, you're going to use epinephrine 1 in 1,000, and you're going to give 0.1 to 0.5 ml sub-Q, possibly every 10 to 15 minutes, depending on what type of reaction they're having, okay? So we could give that. A lot of times what you're going to see is that in the nurses that see this the most are the emergency room nurses, okay? So we have those injectable. A lot of times we've bought injectable pens that are a pediatric dose and an adult dose that we're going to give them. Now, the thing is that you guys will see those vials that I showed you in the crash cart, that one that was 1 in 1,000. And that is because that's cheaper to buy it like that versus those pens. So you've got a bottle that maybe cost $20, $30. I'll have to, and the nice thing in Nursing Central even kind of gives you the going price of what the cost is. And then you'll have that, or you'll have the injectable pens, which most places have gone to because they don't want the nurses to make a mistake, right? This is a quality improvement initiative, right? That, it's going to be worse if we don't give them the right dose of that medicine. And so they're using the injectable pens, but that costs about $120 to $150 for those injectable pens versus buying that little bottle. So this is a big drug that we want to be sure we're using the correct dosage and the right mechanism for that. And you guys are going to, depending on where you work, you want to make sure you understand what you have available to use with the patients. Okay. And that 0.1 to 0.5 is that smaller dose, because a lot of times when we're pushing in a code, it's that 1 milligram. So this is the same medicine, it's just a smaller concentration for this type of anaphylactic. All right, so antihistamine we can give, IM or IV, steroids if it's really bad with systemic. We're going to possibly give in fluids and volume expanders, so you're going to be starting that IV. Some vasopressors depending on what's happening. vital signs wise with blood pressure and heart rate, and then possibly some aminophylline in there. All right, so there's the local versus the systemic reaction that we can look at. All right, the type 2 is a cytotoxic reaction. So that is a transfusion reaction can fall into that. And cytotoxic meaning it is destroying cells in there. So direct binding of the Ig or IM antibodies to an antigen on the cell surface is happening, okay? So with transfusion reactions can fall into that. Goodpasture syndrome, which affects the lungs and kidneys. It's a rare autoimmune illness characterized by progressive glomerular nephritis, hemoptysis, which is that coughing up of that blood, and the heterodiciosis, which is that excess deposit of iron in the liver and spleen, and renal failure, which usually leads to death with that. All right, and then you'll see immune thrombocytopenic purpura, where it has those purple spots, and then Graves' disease, which is that hyperthyroidism, which can cause autoimmune destruction of the thyroid gland. Okay, so there's a couple examples of that. With transfusion reactions, you're going to see that you're going to have 3 different types we can have. So we have an allergic, right, where you have that flushing faces, hives, and rash. You can have a febrile one, or you can have a hemolytic. So which is the worst? What's the progression? Does this go in progression, the way it's kind of sloped down to the side here?
I would say so.
Yes.
Yes, it is. So before we give blood, a lot of times the new thing to do, probably in the last, I'd say 10 years, is what drug can we give before we give the blood is given, and a lot of doctors will order this to prevent this allergic reaction where you have possibly hives, rashes, facial flushing. So this is kind of standard. Yeah, so we'll give a dose of Benadryl, usually about 25 milligrams, maybe up to 50 for that. So that'll prevent that part of the reaction. What's the drug we'll give to prevent the febrile part of it, with the headache, the tachycardia, the tachypnea, fever, chills, anxiety? Yeah. So a lot of times you're going to see they're going to give acetaminophen or Tylenol for that second transfusion reaction. And then the hemolytic, we just don't want that to happen at all, right? We don't want to give the wrong blood. We don't want to. But with that, you're going to see where we drop our blood pressure, increased respiratory rate. We can have that tachycardia where it's compensating, and then it might fall from there. Headache, chest pain, apprehension. So as soon as we have anything like that, when we're giving blood, we're going to stop that right away. Now, what you have to do is, because there's blood in that tubing and we have normal saline, we have a Y connector. Let me see if I have this on here to show you guys. Yeah. All right, so we've got this Y. Here's our blood and here's our normal saline. So you're going to see where we have a filter right here, and we're going to hang, a 500 bag, 1,000 bag of normal saline, depending on what we have, and then we're going to hang our blood for this patient. So we're going to talk to them about allergies, see if they are. One big question we want to ask them is, do they have they ever had a previous transfusion reaction before? And we want to administer that blood within how many minutes did we say we want to get hanging on that patient's blood?
20 minutes.
20 minutes. Sometimes the hospital will give you 30 minutes, but that's the average time. We're going to do that cross match and check with another nurse, right? 2 RNs have to do that. And we're going to look for the ABO group, the pH type, the client's name, the hospital number, and expiration date. And we know if anything is off, we're not going to hang that blood until that gets resolved. If their armband doesn't match that blood product, we're not going forward at all. All right. Do not warm unless risk of hypothermic response. Now, we talked about that with blood having to be warmed. And a lot of times, some places will just automatically warm that blood. So you'll find out protocol-wise what your facility does. And then we want to infuse each unit over 3 to 4 hours, but no longer than 4. So our minimum for non-emergent blood is 2 to 4 hours is our time frame. I want you guys to remember. So now if the patient has like a heart failure, would you think we want to slow that blood down? Would we want to give it as fast as a younger, healthier person? A person who's maybe just coming in with anemia, and yeah, so you're going to want to slow that down. I've also seen where you give some Lasix in between doses or bags of blood. Okay, so you're giving them, usually in a bag of blood, it's about 250 cc's, 250 to 300. So when you guys are donating blood, if any of you guys have donated, that's about how much is in that bag that they're collecting. They're taking about a 250 to 300 cc's of blood off you. So that is what's in those bags of blood. Okay, so never add any meds to blood products. We just don't do that. Okay. A lot of times if we're going to give Lasix, I've even seen them do inhaled Lasix. If like I had a respiratory patient who had bad COPD and she had it in, we'd put it in our nebulizer treatment, and that's how she would get that in between blood transfusions. So you're going to check the doctor's orders, check the labels on the blood and the client's ID bag. You're going to do those baseline vital signs. So you have to get those vital signs right before you're about to hang those blood, so you know where the temperature was, where the blood pressure, heart rate, all those vital signs were before we started that blood. We're going to have a filter that it's going to go through. Now you'll see some places will let you hang 2 bags of, because a lot of times when people come to get blood, a lot of times they get two units of blood to bring them out if they really want to, if they're running below that hemoglobin of 8. So you'll usually, sometimes the facility will let you use 2 bags with that 1 filter. So you're just going to change the bag with that blood bag with the tubing there. And then some places want you to change out the tubing, the entire tubing, every single bag of blood you give. Okay. But standard for a long time, we would always give 2 units off that 1 Y connecting tubing with that filter in it. Okay. And you'll see that next semester. You guys are going to be working with blood next semester. All right. So normal saline is always the fluid we're going to hang, nothing else besides normal saline. Now, if this guy's got a reaction and the blood's down here, so when I start my blood, I make sure my blood tubing, I flush the normal saline through the tubing, then I flush the blood through the tubing, and I bring the blood all the way down to here, you know, and flush that normal saline out to where when I'm hooking it up and I'm starting the blood and I'm in that room the first 15 minutes with that patient, that patient's getting the blood right away, right into that IV that I've just started. So I can see, because if they're going to have a reaction, I want it to be when I'm in the room and I can stop it right away. Then I'm going to have to take that entire tubing down and a lot of times send it to the lab so they can test it. But I'm going to have another bag of normal saline to put that onto that hep block, because I don't want, if they're having a reaction, I don't want to wait for all this blood that's in the tubing to get into them first with that normal, to get the normal saline going. Does that make sense? Okay.
Yes, ma'am.
All right, good. For severe reactions, most likely happen in that first 15 minutes and the first 100 cc's. But I have heard of reactions happening within, they say in the textbooks, I had a girlfriend who was one of the lab managers, and in her book, they said you can have a reaction as small as 15 cc's of a blood reaction. Okay, that small of amount can set off someone to have a bad reaction. Severe change out the blood tubing and filter with, now this says each unit, but you'll have to see in your facility if they want you to do 2 or 1. So, and then return completed transfusion bags to blood bank after that, because they're going to retest it and try to figure out what's happened if they've had that bad reaction. All right, hypersensitivity type 3 is involved in the antigen antibody reactions. It is inflammation may be targeted, and we know that's one response to happen when we're having a hypersensitivity or any kind of injury that might happen. Systemic infection may result. Reactions are not immediate with a type 3, and disorders can be the serum sickness, lupus, or what's RA? What do you guys?
Rheumatoid arthritis.
Rheumatoid arthritis is a big one when we think of hypersensitivity, and treatment depends on the cause. Okay. So, let's see. So serum sickness is adverse immune response following administration of foreign antigen. Example is an anti-serum obtained from horses or other animals. Animal serum was formerly used for passive immunization. So that's why you would see patients having that type of reaction. So that's why you'll hear people say, okay, how was this vaccine made, right? Do they want to know if it was made from eggs or other animals? Or so you'll hear, because people will have reactions to those. And so that's a big question with vaccines that people will want to know. And that's why you'll hear that information being given out by different companies of how exactly the vaccine was made. Okay. Type 4 is this delayed hypersensitivity. So what can happen, for instance, this blood transfusion, they can have a delay. So it can be hemoglobin hematocrit decrease approximately 7 days following a blood transfusion. All right. So this is with blood transfusions, you can see that. And then graft rejection. So if we put some kind of maybe a skin graft on a patient, or those are kind of the main one that you'll see. So you're going to start seeing fever, malaise, fatigue. So they're going to fight against that, right? Localized graft area tenderness. So a lot of times we graft stuff with skin, possibly, and then hypertension, leukocytosis, and elevated ESR. When an ESR will tell us inflammation, okay, which is another name for a SED rate that you'll see. All right, other sensitivities, latex. So that was a big thing with healthcare workers that we would see problems with, was latex. So what have we done? Do you guys know what we've done with products that had latex? What we've done for a lot of healthcare providers, because quite a few were having, what's that?
Gotten rid of the latex.
Yeah, we've got rid of latex-free gloves. You guys will see we actually have a cart that is at one point where it was all latex. So they've gotten a lot of the products where they don't have latex in them anymore, but you will see that there still are some. So common household products that you guys can think of when a patient comes in can be balloons. So say they're at a party and they're having balloon, dishwashing gloves. If you guys look on the packages, some of them still have latex. Condoms and diaphragms, that was another one that patients would have reactions to. Telephone cords, rubber bands, and then infant feeding nipples. So you'll see where a lot of them are trying to get away from using the latex. And then common medical products are blood pressure cuffs. A lot of times they're in a sleeve, so we don't have that latex right against your skin. Injection sites and vial tops had latex in them. Foley catheters, gloves, wristbands, IV bags, and tubing. So they've tried to get away from all of those products, but you'll still see people having reactions to this and coming in, and you'll have to ask those questions and trying to figure out why they've had this kind of reaction to whatever they're doing. So there's occupations, for instance, that use latex. So what are some occupations that you guys can think of that might come in with problems to a latex sensitivity? Anybody think of people who wear, yep, people serving food in the food business, manufacturing, good. Yep. You'll see daycare, a lot of times if they use some gloves where they're cleaning down toys and cleaning up rooms. Teachers, yep, janitorial services, and hair stylists will have issues because they wear gloves also. So these are some jobs that when you think of that, when they come in, those are going to be some questions that you're going to try to find out if they're using some kind of product that still has latex in it. Okay. All right. So drugs we're going to use to treat these allergic reactions. We mentioned them before: antihistamines, bronchodilators, and adrenergics will be used depending on what they've come in with. All right. And then we talked about autoimmunity. So that's us attacking our own cells, the loss of tolerance to self-antigens when immune systems no longer differentiate between the self and non-self. So the big one you guys have mentioned is the rheumatoid arthritis, systemic lupus erythematosus, or SLE, pernicious anemia, myasthenia gravis, insulin-dependent diabetes, and then the scleroderma are the ones you'll see. So that scleroderma, chronic manifestation of progressive systemic or sclerosis in which skin is taut, firm, and edematous, limiting movement. So hardening or induration of an organ or tissue, fibrotic tissue, will happen with that. All right, so here are some things that you'll see with the SLE, or the systemic lupus erythematosus, or lupus patients. So the big things you'll see is that mallard rash. So I wanted to have you guys see, which is that butterfly right here, where you see on a lot of times on a person's face that they come in with butterfly rash, cheeks and bridge of the nose. And then this discoid rash, where it looks like it's slightly elevated and flaky, but it kind of has a darker outline, and then the paleness inside that rash. Okay. A couple other things that will happen with the lupus is that photosensitivity. Sometimes they'll have oral ulcers, arthritis, keratosis, the renal disorder. So you'll have neurologic, renal, hematologic, immunologic, and then anti-nuclear antibodies that will be happening with that. Okay. With that, patients experience those painless oral ulcers sometimes during their illness. So different things that we're going to consider is corticosteroids, non-steroidal anti-inflammatory agents. Some anti-malarial drugs will work for that. And then plasmapheresis, where we take the plasmas and we clean up the plasma and then give that back to them once we filtered it. Okay. And then we have to do our complete assessment, look for what the goals for that patient are, protect them from stress and fatigue because that will make their symptoms worse, protect them from infection and fluid volume imbalance, protect from injury, and then manage the pain if they have any, okay, with those sores or whatever else they have going on with that. All right, and then immunodeficiencies here. We talked about, and we're going to look a little cell-mediated response, humoral response, the phagocytosis, and then we can have a combination of those that will work to help with this issue. And then here's some different primary disorders that we'll see. And then we're going to be talking about HIVs. So with this DiGeorge syndrome, you're going to see it's thymic hypoplasia, which is a missing gene on chromosome 22. It's 22 deficiency, and it's a component of the T lymphocytes and the cell-mediated immunity. So with that, we're basically missing a gene that's causing us to have that. There's severe combined immunodeficiency disease has defects in both the B and T cells, and immunity responses infrequently include defective cytokine function. So that those mediators that tell us, hey, we need to fight against this virus, they have defect in that, where we're giving off those signals they're doing. Okay. All right. But HIV is our big one that we're going to talk about. And you'll also see with immune deficiency where we have a lack of protein and calorie malnutrition that happens with them. So we have what's called a wasting syndrome. They have a decreased inflammatory immune response and the increased risk of infection from molds and spores. Okay, so you're going to see patients like this, especially you'll see a lot of this with cancer patients that we have to do. So we can see characterized by weight loss, diarrhea, night sweats, fever, and anorexia. And then we have to work on giving low residual diet, no fiber, no seeds, and no milk products. So, which is going to help just make it worse. So we want our protein intake to be 1.2 to 1.5 grams per kilogram with them. We give a drug that you're going to, whenever you have a patient who has like a wasting syndrome to where they can't keep weight on and they just look so hollow, is the kind of description you'll hear people talk about, is we give a drug called Marinol, and we do this for this immunodeficiency, and we give it for chemo patients to where we're trying to increase their appetite to make them want to eat. It's a synthetic wheat. Oh, I don't know that I knew that. That's cool. So yeah, okay, Avery, you taught me something with that. So, and I've used it for a long time to try to get people, and sometimes it works for a while and sometimes it doesn't, right? I see some success with it, not. But other things you want to do as a nurse for these people who haven't, the big push that I always tell is if you can because they get to the point where they can't eat they just don't want to eat at all, and they don't want to eat. And if they do, like, I'll have nurses where they're on this low residue diet, right? And then the family will bring them in like a milkshake that they love, or, you know, a hamburger that they want to eat and stuff. And my whole thing is, if you can get something into them, because these people just aren't eating at all, then I'm good with it. You know, if they can eat some, because they need to get some calories on board. Now, some nurses are like, hey, that's not the diet that they're on. But I'm like, listen, I don't, you know, they need to eat. They're wasting away, basically. So different things you guys want to do with that for any of these type of patients, if it's an immune deficiency or a cancer situation with chemo and radiation, is you want to create a pleasant meal environment. You want to teach them about what we're trying to do, that we really need to get them to eat. Encourage the low residue, high calorie diet, and monitor effects of those treatments. Okay. So you just want, even if they want to eat alone, like whatever environment makes them more comfortable to eat. So if it's, they want all their family around to eat, or they don't want their family around to eat, whatever you can do to get them to get those calories is important. Okay. All right. So there is HLA, which is this human leukocyte antigen. It is responsible for the rejection of that genetically unlike tissue. So this is in relation to us doing like a transplant of maybe kidneys is a big one we do, heart and lungs. We're doing lots of lung transplants with COVID that have been successful for patients, because their lungs are so scarred and fibrotic after COVID that they're actually doing, I think they're up to maybe 80 transplant was the last number that I heard last week for lung transplants. So what they're looking at, this is a series of linked genes on the 6th chromosome, and it's important for us to test this to make sure to hopefully get the tissue to match when we do transplants. And it's this major histocompatibility, call it a major histocompatibility complex that they're testing out. Okay. So we know these are our common organs that we're transplanting: corneas, kidneys, skin, bone marrow, heart, valves, bone, connective tissues, lungs. We know that like UT Southwestern over in Dallas is a big transplant center. So I know that some United Regional patients have, we've kept them on a ventilator, for instance, in the ICU to do organ transplants. So because we have that big center in Dallas, and it's nice. We're in, I keep saying I'm going to do this for you guys for 4th semester is Connect. I knew the lady really well, one of the lady program directors over there. So she would give a report of the area of how many transplants were done in our area to kind of tell you what all they're doing. It's neat what all they do. And they use, it's amazing. Do you guys know, we had a situation where it was a young teenager who got into an accident. Her family member decided to donate all her organs. She was actually texting in the car and got hit, got into an automobile accident. And do you guys know how many people one person can donate to with their skin and their bone and their organs? How many people do you think she was able to donate from? Yep, good guess. It was higher. She donated to about like 60 people, because sometimes they'll use bone for like different pace, like when they're putting in like new knees or in the spine. And with the skin, they can make grafts out of skin where they can stretch that skin. It's interesting because they use, has anyone ever seen the old credit card machine that you use where it's kind of, or like a cheese slicer? They basically have a blade where they come and take the skin off, and they take it in like often sheets that they can use. So, and then, lots of corneal transplants when people are having vision problems. And it's just amazing what they can do. It's amazing to hear the stories and all the people that one body can donate to. So, all right, graft versus host disease. This is the immunocompetent cells in a transplant graft attack or destroy vulnerable host or recipient tissue. So you'll see, I had a picture of a little baby where you can see that you can see when it's rejecting, because it looks like a bad infection where it's inflamed and red and flaring up, and that you can see, like, for instance, if we put a skin on another patient or a graft skin where you're replacing that skin where it just gets red and inflamed and it just starts peeling off. It's not going to stay because the body's just rejecting it. All right. And that's a big thing with organ donation. So target organs are skin, liver, GI tract. Biggest issue is infection. So because it's, the body doesn't recognize it, it's not part of me, I'm going to fight it off. So a lot of times, what do we take? What does that patient have to take to prevent this from happening when they get a new organ or new skin? Do you guys have any idea of what we might have to give them to prevent this from happening? We actually give them, immunosuppressant drugs that we have to do that. So they're on quite a few drugs to prevent that from happening. Exactly. Good job. Good job. Good job. All right. All right. You guys want to take a break? Are you okay? Take 5 minutes, 10 minutes. We're at 2 o'clock, I think, right now. Yes. Okay. All right. Let's take a 10-minute break, you guys. Let's go to like 2:10, 2:11. Okay, guys, we are back. So let's go through, we're going to go through chapter 35, just look at the questions and we can look at that stuff here. So if we go to this one, I'm going to assign it back to you guys. All right, and then we're going to go to 35 here. We're just going to look at some questions in there. All right. And you guys can just answer via the chat. It'll be easier. I'm going to do, hold on, you guys. Okay, I can see it here. All right, so if we look through this, same kind of, now here I just want to come to point out that with those B cells, which are, you can see a lot of times the B cells are 10 to 20% floating in the fluid or that humoral response, whereas, hold on.
We can't see your screen.
Oh, sorry guys. Let me share the screen with you. Thank you.
I came back after when you were asking the question. I didn't answer. I didn't know if I missed something.
Nope, you didn't. We're just starting right now. So we're going to look at these questions here. So is the following statement true or false? Immunity refers to the body's non-specific protective response to an invading foreign agent or organism. What do you guys think about that question? If we can just practice a couple questions here. Oh, wait, can you guys see this? Can you see that question? There we go. There you go. Make sure. Good. Yes, that is false. So it is specific, right? The body's specific. Immunity refers to the body's specific, not non-specific protective response to an invading foreign agent or organism. Okay, good, good, good. If you guys see here, and I'm going to blow this up a little. Let's see. We can go up full screen. Let me see. How do I go the opposite way there? All right, so you guys can see a better chart of this or show you where we go from the bone marrow to the lymphoblasts, and you have your thymus, which has the regulator T cells and the effector T cells. And then we have those three different helper T cells, suppressor T cells, and cytotoxic, which is in the cell. And then we have this bone marrow maturation where the B cells or the B lymphocytes, which are going to do that humoral response in the fluid that's floating around. Okay. Let me zoom it down now here. So these are just different types of diagrams to show you guys where we're getting these different cells that are fighting off these diseases in here. All right, let's just go through. I gotta see my arrows here. Okay. All right, and we talked about this. Let's look at the questions in here. We talked about active and passive. All right, which leukocytes, now we talked about this from the last class, arrive at the inflammation site first? Which leukocytes arrive at the inflammation site? Yes, good, you guys, D. So those neutrophils, right? Those new neutrophils, first ones, they arrive first at the site where the inflammation occurs. Good. And then there's, in here, it's showing you the 4 stages of the immune response. So in that other diagram, a little more detailed than the one I had showed you in that other one. So let's go through this. And we see the cellular and the humoral response that's happening. And then the phagocytosis, and then talks about those different responses. And then the antibodies. So just a little showing you how those match up, the exact fit. And let's just go to the questions here. It talks about them at different age, gender, different things that'll happen. And this talks about stem cell, a big thing that's happening. We talked about those stem cells, right? That we're using them in research, using them in lots of clinical trials to fight different types of diseases, like lupus is one of them, rheumatoid arthritis, scleroderma, and that multiple sclerosis, which we talk about in the neuro section. All right, and we talked about the white blood cell. And what did we say our normal white blood cell count was? What's the number you guys were on to remember? How many thousand to, yeah, 5 to 10,000, 5,000 to 10,000, good. And then good job. All right, is the following statement true or false? Autoimmune disorders are more common in women than men. What do you guys think about that? Let's see what you guys are saying there. Autoimmunes are more common in women than men. That is true. Correct. Good job. Good job. And I think that was the last one in there. Okay. So good. Very good. Excellent. Excellent. So you guys can look through that because that's kind of a shorter one there. So, all right. So I'm going to reassign you guys back that, and we're going to do HIV next. All right. Okay, we're going to go here. You guys can download that one. Give you guys a minute. Professor Groth was telling me that she could hear my whole, she's like, I could be in your class right now. I was like laughing. I'm like, okay, I'm going to talk really quiet now so she can't hear anything that I'm saying to you guys. Can you guys hear it? All right. I know, huh? All right. So then she knows what I've covered over there. So, and I think she's working on your test. And she was telling me she was working on your test. All right, let's unassign this. And we're going to present these. All right, we're going to be talking about infections and worldwide. And this will kind of, we'll talk a little about what's happening, you know, right now with COVID and how all that works. So, all right, so anybody, so we know that there's emerging infections, right? This used to not be as much of a deal until COVID happened. Well, I mean, it was always a big deal, but now this is really prevalent because we have seen what's going on. And when I started doing this and talking about infections and pandemics happening, it was predicted that was going to happen in the next 10 to 15 years. And that had been going on for 10 years. So when I started lecturing, I said, they say a pandemic's going to happen in the next 5 to 10 years. And we've seen it right now. Okay. So before COVID happened, lower respiratory infections were the big one, right? Malaria is a big one that we see happening that has caused significant deaths around the world. Tuberculosis, and then HIV. All right. Does anybody know what this, anybody recognize this animal? What type of animal do you guys think this is? What in what link or what area of, yeah, the cat family, exactly. So it's actually a civet cat. It was linked in 2003 to the SARS, the severe acute respiratory syndrome that happened actually in Canada. So Canada, when they had a SARS outbreak in 2003, handled it really well. They actually would isolate people, call the people, and keep them in their house. So the outbreak in China was a small carnivorous mammal found throughout Asia and Africa. And it was zoonosis is the study of disease transmission from animals to human. So when COVID came out, what were they thinking it was transmitted? What was the kind of news on the street to where COVID started? Yeah, bat, remember? And bats are a lot in other countries. Like I remember being in Guam and I remember seeing a bat in a cage. I've never seen a bat before up front where I could actually look at the bat, you know, and they were a lot like in caves that we would go hiking into and stuff. So yeah, the bat was that thing. How does West Nile spread? What's the animal that West Nile is? Yeah, the mosquito, right? So you'll see lots of initiatives because we had a lot of West Nile happening in the Metroplex and in this area where, and you'll still see it, they'll be spraying like at dusk when the mosquitoes are really bad, and they'll be, they have trucks that they go around with and spray when we get to the summertime. And does anybody know the early warning sign for West Nile, which is like you start kind of looking at your environment and something dies that you see, yeah, dead birds is a sign of West Nile. So a lot of times those mosquitoes will bite those birds and they'll die from West Nile. And if you start seeing dead birds, I remember I was in town and there was a dead bird and I was like, oh my gosh, we're having a bad outbreak of West Nile. And I think someone had accidentally killed it with a slingshot or something. And they're like, that didn't die from West Nile. I'm like, okay, all right. So yes.
Can I interject something? I was listening to something recently. I don't know if it's going on in Canada, but it's with the birds, dead birds. This lady was finding them in her yard, and they're thinking that it's linked to because of the COVID. People were putting bird trees, bird houses in their yard, and these birds are they were found to have salmonella. And that's what's killing them right now too.
Okay.
So
yeah, it's interesting because we can see, because the animals are smaller, you can see those signs of this in animals sooner than you can humans, basically. So when that SARS happened in that 2003, which is a type of kind of linked to the coronavirus, Ontario, Canada, and this is the difference that they saw 430 probable SARS cases with 44 deaths. In China, this was in November of 2002. So it was a person in Canada went for business to China and brought that SARS case back to Canada. So we kind of knew before this in 2003 how best to contain it, because Canada did such a good job. China had 8,098 cases, and they saw 774 deaths in 37 countries, and a majority of it was in China and Hong Kong. Okay, so we had some examples of how to self-contain some of these things that were happening with infections. We know that pathogens, they can be those bacteria, viruses, fungi, protozoa, or prions. So protozoa are those single cell animal-like microorganisms. And we get a lot of those because of our overuse of antibiotics by healthcare providers. And then those prions are those infectious agents composed entirely of a protein material. Okay. And we know that the battle against infection isn't new. We've been doing this for years and years, but our global travel and our modern technology has totally changed the rules. So with the development of these vaccines specific, like the Moderna and Pfizer, what if they said we're going to be able to cure a lot faster with this virus being this new technology in the COVID vaccine? What have they been telling us that we've made? And I might have mentioned this, 10 to 20,000 year leap, not thousand, 10 to 20 year leap of cancer, solving cancer things that we can treat. Oh my gosh, you guys can't even talk. Yeah, future issues, future problems, it could be, but hopefully the doctors would say we have moved that scale of what we can do with hopefully treating cancer by the speed up of this technology that we've been doing with COVID vaccine. Okay, so hopefully that is the case. All right, so what we know that public health, right, is the type of nursing that battles this worldwide problem, that a lot of vaccines, it was interesting because I was listening on the news that this area in Baltimore doesn't have a public health department. So they have been having to use other agencies they're not getting as much vaccine, or distribution of vaccine hasn't been happening in that area because they don't have a public health. So their state downsized public health and they don't have a department in this particular county, a large county area, and they're not getting the vaccines, like the people in those counties aren't getting vaccines. So there's people who are having to step in and try to correct that issue. So in coordination with the CDC, where's the CDC located? The Center for Disease Control. Do you guys know where that actual CDC is located in the United States? Georgia, in Atlanta, Georgia. Good. Yeah. CDC's in Georgia. And we have the state health departments that will take the lead on this. What different clinics do you guys see that are found in public health? What clinics have you seen that will treat? I know you guys, some people might have gone over to the different departments. Vaccination, right? They have vaccines. Women's clinic, yep, there's a women's clinic in there. There's tuberculosis clinic in those public health departments. We used to have the STD clinics, but we don't call those anymore STD clinics. We call them, does anybody know the name that we call an STD clinic? Now they treat the patients with STDs in this clinic, but they call it the adult health clinic. So if you're like, I'm not sure what the adult health clinic does, it's a new name for the STD clinic. Okay. So it's amazing. They have different technology that I like to tell you guys about that. Yep. WIC, women, infant, children, they'll do that. Where we've had episodes, for instance, they have an epidemiological tracking system, right? And it first got implemented probably about 15 years ago for the first time, where they would feed that information, for instance, with COVID, the ICU beds. This tracking system, like in the DFW area, they have one. Tarrant County has one in Dallas County. So they know all the hospitals feed their information into this system to know how many beds are available. So if the ambulance has to take patients to one hospital because we don't have enough ventilators there or in open beds, they'll go to another hospital. So that's when they talk about incident management system or incident management command centers opening up. It's these command centers that open up for disasters, but a lot of times the healthcare medical component always has a seat at the table because we're usually dealing with the bad cases of what's going on in a disaster. All right. So when this surveillance system opened up, for instance, the first thing that happened is they'll also, along with the hospitals, they'll track pharmacies in the system. So the first time when they did this, they opened up and all of a sudden Pedialyte was being bought off the shelves of the pharmacy in the Dallas-Fort Worth area. So what do you think was happening? What would you guys assume was happening if all the Pedialyte is being bought off the shelves in the pharmacy? What would come to mind for you guys? Yeah, like what diarrhea with what type of patients would you guys think? Like no one wants to talk to me besides Kristen and Valerie. Yeah, pediatric patients, right? Where we think they're sick, right? That there's sick children happening, that we have some kind of a disease that's causing children to be sick. No, what was actually happening was there was going to be a rave party. Yeah, Michelle guessed it. There was actually going to be a rave party. And before the party, they told the teenagers to drink Pedialyte and use that before you go to this party so that you won't have that problem that Michelle mentioned here. And then, of course, they were able to find out that this party was going on. The second incident that happened when this first started was there was a bunch of little children that were going into 4 different area hospitals into the emergency room. So this computer tracking system can hit and ping the health department when something is being overrun, basically. So what happened was there was a child care center that they had a carbon monoxide leak that happened, and they were telling the parents to take the children that were having issues to get checked out in the emergency room to make sure their oxygen was okay, that they weren't, I think they were drawing some blood, make sure everything was okay. And so even before the daycare center called the public health department, public health knew about it because of this tracking system that we have. So this is so if you guys are hearing numbers about COVID and the statistics and the bed counts, they can get all of this information because the system has been running for about 15 years across all the states in using the CDCs and telling us this type of information. Okay. So our technology has been awesome in that sense. So, all right. So I always like to kind of see a show of hands of who was born in the States, who wasn't. And so we kind of look at what I'll ask them about, who's been in contact with anyone who has actually had HIV, had malaria, or had TB, and then who hasn't. And we kind of I look to see who has more exposure to that, because we know that other countries are still battling. The United States has issues, has these problems also, but not compared to the world if you look at other countries that are dealing with this. So this is a map to show you health myths. Does anybody know what health myths are? TB and malaria. And it tells you this is big outbreaks in these. Yeah, so Avery said, I have friends that travel to Thailand all the time and they both have malaria. They both had malaria. Okay, so how did they have to be hospitalized for their malaria? Or did they have, did they take antibiotics? Let's see what she says on that. No, they just get meds and they're fine. Oh, good, good. So when some people come back and they get very extremely sick and have to go into the hospital and get IV antibiotics for it. Helminths are worms. So, and it's worms that get in. A lot of times it gets into the drinking water, and then it like tapeworms that they have to get out. So yes, so lots of other countries, you know, like Bill Gates is a big HIV, puts a lot of money into looking at the world. We've eradicated, what is the one disease that we've almost eradicated, except for a couple cases? I think they said there was like 15 last year, or in the last couple years of them tracking it. Yeah, polio, right? Due to vaccines, that's one that we pretty much eradicated. Good. All right, let's look at HIV. So globally, we can look at the last numbers where there were 33 million globally living with it, 2.7 million in new infections each year, and 2 million HIV related deaths. Okay. So currently we have 325 million people living in the United States, and we have about 1 million cases in the United States. All right. So the big thing with, so it, you know, HIV was considered our biggest pandemic before COVID. All right. And retrovirus. So the main thing with HIV, it's a retrovirus that causes immunosuppression, making people susceptible to infections. So HIV disease is interchangeable with HIV infection. And the most devastated areas have been the sub-Saharan Africa, the Caribbean, Asia, Eastern Europe, and South America. Okay. It was identified, we know, in 1981. So, and it was of the infectious diseases. If you look at HIV, what's the most contagious? If you're looking at Hep B, Hep C, and HIV, what is the most contagious one? Of different diseases that are happening worldwide. Any idea? So we get hepatitis vaccine, right? It's actually hepatitis B is the most contagious at 33%. All right. Hepatitis C is at 2%, and then HIV is 0.333%. Okay. So good. All right. So what happens, we'll see, we've had major advances in the last 30 years with HIV for prevention, testing, and treatment. So treatment has resulted in a longer life and lower death rates. So in the United States, those 56,000 new infections each year, and it's the problem with that is highly associated with lifestyles that disenfranchise most of society, right? We've had a huge decrease in the number of children born with HIV, and we know that the prevalence in North America is highest among men that have sex with men, but women, people of color, and people who live in poverty and adolescents also contribute to the new HIV infections that are happening. Okay. All right, so HIV, it is a fragile virus, and it's transmitted only through the contact of body fluids and under specific conditions. All right, so if you look at this, the majority of transmission is heterosexual sex, and women and children bear a large burden of the illness. Okay, so the most common transmission is that unprotected sex and with an HIV infected partner. All right, and what happens is you're going to see where the infection is greater for the partner who receives the semen. Okay. So this occurs because the receiver has prolonged contact with the infected fluids, and helps explain why it's easier to infect women than men during heterosexual intercourse. Okay. In addition, if you have genital lesions or other sexually transmitted diseases like herpes and syphilis, that it can significantly increase the likelihood of the transmission. Okay. So we know that it's blood, semen, vaginal secretions, and breast milk, and the sexual contact with that infected partner is the most common mode of transmission, like I said. All right. So what happens with this sexual activity? It comes in contact with the semen, that vaginal secretion, and or blood, and all have lymphocytes that may contain HIV. Okay. All right. So another different ways that we can see the transmission is that shared needles. So you'll see where it was interesting back probably about 15 years ago, 20 years ago, there was a program where you could get new needles, right? So if you were a drug user, we knew we were spreading HIV in the United States in particular, just because I knew of this area, where they would come in and they could get clean needles, right? Because they were using dirty needles. So that was, I don't know that we do that as much. I would have to ask the health department about that. But that's one of the shared drug using equipment, risky, some things they were trying to do, kind of out of the box ways to try to help with this. Infection through transfusion of blood or clotting factor is now unlikely because we've implemented such good screening measures when we go to give blood, right? We ask a bunch of questions, we screen for it. People were getting HIV through drug transfusions in the past, but that has gotten down to nearly nothing, for that, okay? Now it's like at 1%, they say. And then puncture wounds are most common means of work-related transmission. So it is really low to catch that. It's 0.3 to 0.4, and we said it was 0.0003, which is even the lower number that they've just recently put out. So what do we do if we get a stick by any kind of dirty needle, which a lot of needles that are a lot of healthcare entities that I would see happen was a lot of times in the dental area was an area where they're using lots of equipment. They're cleaning up sharp equipment, and those healthcare employees were the ones that I would see the most with having issues with puncture wounds, with cleaning up instruments. So we've done lots of quality improvement to try to prevent that from happening, from getting a needle stick. So if you get stuck with a clean needle, are we good with a clean needle? We just stick ourselves while we're doing an IV and we haven't even approached the patient yet. We haven't put it in. Are we good with that? Yeah, we're okay with that. Now, as the dirty needles, we poked ourselves, we put that IV didn't go back, we hit the button and it didn't go back and we accidentally get stuck. What are we supposed to do right away? What's the first thing you guys want to do if that happens to you? Well, before that, even before you guys report it, what do you want to do when you get stuck with a dirty needle as soon as it happens? Bleed it. Yeah, bleed it first. So you want to bleed it. You want to take it and try to get blood out of that finger where you poked it. Okay. No, it's okay. Tell the charge. You are going to tell the charge. You guys are right on that side. So you want to bleed it out first. And then what do you want to go do? What do you want to do with soap and water? Yep. You want to wash your hands really good. You want to bleed it out by just pushing it. Like for instance, if I got poked in the finger, I want to bleed it out. Make sure I do that. Go wash my hands. Then I want to report it to my supervisor. So it could be the charge nurse, it could be the nurse manager, whatever we're calling that person. And then what's the area that you guys are going to get sent to that they're going to do an assessment on you and figure out what we need to do with that. Now, a lot of times they'll send you to the emergency room, okay? Because the emergency room is going to have the step-by-step guidance of what we're going to do. So a lot of times what we want to do with a patient that we get stuck with, we're going to test that patient's blood. And a lot of times when they sign consents, when we come into the hospital, you're signing in consent if someone gets stuck by, a lot of times they have that in the wording, that if someone in the healthcare department gets stuck with a dirty needle, that they will be able to run your blood to see if you have, what do you think the big things they're running your blood for? what are the infectious diseases that they're going to run that patient's blood, because you just stuck yourself with their blood for those 3 that I just mentioned when we talked about the percentage. So the HIV is one of them. And what's the other 2? Hep B and Hep C. Yeah, exactly. Good. So then we're going to track you. Now then, if we have a employee health, that's one of their job. If someone gets stuck with a dirty needle, that they're going to track that and see, they're going to look for that patient's results. Now, if that patient comes back and they're not positive with HIV, Hep B, and Hep C, is that a good thing? Is that a relief to you if you find that out? And I've just stuck myself with a dirty needle. Yeah, that's a good thing, right? So how do we know about HIV positive patients that we work with directly report and chart? Yeah, that's a good question. So some places have that in their chart, right? In some places you find that out after the fact, because it's not a designated thing that they have to put in the chart. So it'll be interesting. I'm not sure what exactly, like for instance, what Epic does. When you guys go to United Regional, I'll have to check about that. But yeah, you won't necessarily know that they have that off the bat. And so it's just a matter of testing to see if they're positive for that if we get stuck. So, and that'll go from like the emergency room where we do, because that situation can happen anytime during the day, you know, like it could be day or night. So you want to be routed to a place where they're going to, you know, be able to do that protocol for everybody depending on what shift they are at, right? So that's why we put it in the emergency room department. And then we follow, the doctor will check you over, you guys will have a plan. A lot of times people don't like to start on those antiretrovirals, the medication for HIV, because it has a lot of side effects, right? So, and then you're kind of waiting for reports to come back. And then a lot of times that the employee health will be coordinating what else is going to happen with that. But hopefully that won't never happen to you guys. All right. With all our needleless system and everything we use, because we still use needles, but we have gotten really decreased sticking. So healthcare workers actually have a really low risk of acquiring HIV at work, even after a needle stick, if we do those measures, okay? All right, so with the thing that we see here, prenatal transmission, it occurs during pregnancy, delivery, or breastfeeding. So an average of 25%, this is a high number, I always think, 25% of infants born to women with untreated HIV will contract the infection, all right? But if you take treatment, which is those antiretroviral therapies, or ART, you'll see them say ART, which is the medications, we can reduce the transmission to less than 2%. All right, so you can see, is it important for us to treat these pregnant women? Do you guys see by these numbers? Definitely, right? Yes. And that's a big push in other countries that we work to do, okay? All right, this is a chart I like to show you guys because this shows you how a person contracts HIV, okay? And kind of gives you a chart of this. So we have, what happens is they've been exposed to HIV, right? So the HIV individual can treat HIV to others within a few days after becoming infected, all right? The transmission of HIV is subject to the same requirement as other microorganisms. Large enough amount of virus must enter the body of a susceptible host, right? And then the variables that influence whether the infection will be established after an exposure is the duration of the frequency of contact with the organism, the volume, virulence, and concentration of the organism, and the host immune status, all right? So what you're gonna see, if you guys see across from 2 to 12 weeks, what happens is they've come in contact with an HIV patient or someone who has HIV, and then they have this huge viral load in the blood system, okay? But in the meantime, they have their own CD4 T cells that are there that's gonna fight it, okay? So, and then what happens is we're also gonna have antibodies that are gonna be developed to fight against it. So you have all 3 of these in play with HIV, but this person now has caught this HIV. So they start having, in about 2 to 4 weeks, they start seeing flu-like symptoms. And that's why when you first get infected with HIV and they have this big, huge viral load, you don't, no one picks up on it right away because it seems like it's just flu symptoms or a cold symptoms. Okay. But they're actually having this acute phase of where they're getting this virus and it's replicating in a large load into our bloodstream. Okay. So then what it shows is you guys can see that we have those T4 cells that are fighting off. We have antibodies that are fighting off it. So if we leave HIV untreated, all of these lines intersect in the 8, 9, 10-year mark. So that is when we are going to go into the chronic stage where our body can no longer fight off HIV. And that is where that virus is going to take over and kill us in that if we don't have treatment with the drugs. Okay. So that's what that's showing. So about, you hear them saying about 10 years of no treatment is when HIV is going to kill a patient. Okay. All right, so we know modes of transmission, that there was lots of data out there. It's not spread by casual contact, no hugging, no dry kissing, not shaking, not sharing eating utensils, not using toilet seats. So when it first came out, I mean, people were like, I'm not going to a laundromat. I'm not. The one thing that I did see, the only thing of transmission of like an HIV STD disease that I've seen that was where the organism growed on a tanning bed was when people would tan without wearing anything, and then a person would catch herpes from that. So that was like a contact mode of way of spreading it because that tanning bed. And I remember hearing a conference where the doctor had seen herpes. Someone had gotten herpes from another person from a tanning bed, because what kind of environment is that tanning bed to let that virus grow? What in particular helped? Yeah, that warm environment allowed that to grow to where if a person sat down on that tanning bed, they were also able to contact it too. So that was one way at that, that still exists, that you can catch something like that. All right. So what happens with the pathology of HIV? It's called ribonucleic acid virus. It's caused by a retrovirus because they replicate backwards in a manner going from RNA to DNA. And the RNA virus that was discovered was in 1983, 1981 when we started testing for it, but then they realized it was an RNA. It binds to the specific CD4 and a chemokinin receptor to enter the cell. So we said that large viral levels in the blood for 2 to 3 weeks. And we're going to see that's when that load is the highest, and then followed by that prolonged period of a low viral load, right? So we get that high one when they first catch it, and then it stays low until, that time frame that I told you guys about. All right. So you're going to see symptoms, flu-like symptoms that we would see with that during that acute viral load was increased fever and night sweats. So people would just chalk that up to just having the flu or a bad cold. All right. So with our immune properties that we have a problem with are, well, this is the thing that you guys want to pay attention to. This is one of the most important things. Immune problems start with a CD4 T cell count that goes below 500 cells per unit liter. Severe problems develop when we go below 200 in our CD4 T cells. But our normal range, you and I's normal range without any kind of disease, is 800 to 1200 cells. Okay. And then with that insufficient immune response, we get these opportunistic diseases that happen with HIV. Okay. But our T cell count is the thing that we always talk about. Again, here's the timeline for untreated HIV infection. So we have this acute infection, 1 to 3 weeks, sometimes they say up to 4 weeks. HIV positive tests, HIV antibody test becomes positive. And we're going to talk about that. So asymptomatic infection that we have for this whole time, and it can last up to this 8-9 years. And then we start seeing symptomatic infection. And then we start going down to the AIDS category, okay, in that 10, 11, 12, 13 year, okay? All right, so we talked about this: fever, swollen lymph glands, sore throat, headache, malaise, all these different things that you'll see like a flu-like symptoms. Occurs 2 to 4 weeks after infection, lasts for up to 1 to 2 weeks. Asymptomatic infection, so mean interval, they're saying 11 years. Sometimes you'll hear 10 years, kind of in that time frame, 9 to 11. The years between infection and diagnosis of AIDS. So they're going to see fatigue, headache, low-grade fever, night sweats, prostaglandin and other symptoms, not aware of infection status, thus continue usual activities, which may include high sexual or drug-using behaviors causing serious public health problems in that time frame. All right. And then we see that symptomatic infection. So our T cells drop, our viral load increases, symptoms seen earlier phases become worse, and other problems develop, and HIV can advance to more active state in this population, or this as this goes along. All right, here's some of the side effects. Here's some of the things. Once our count gets too low, we're going to start seeing different things like this. What is this? Oral thrush. Has anyone seen oral thrush in any kind of patients that were having issues? So this is what it looks like. It's Candida rarely causes problems in healthy adults, but more common in HIV infected individuals. Do you guys, what do we treat this with? Has anybody treated any kind of, what do you guys think we treat this with? It's, yeah, good, Nystatin. So yes, Nystatin. We can do a lot of times in the hospital, we do a swish and swallow. It's yellow. And it, we also have a new lozenges that they can use and suck on, okay? So for the mouth, it's really sore. A lot of times we have to do it 4 times a day, and they have to keep it in their mouth as long as possible. So they want to swish it around as much as they can. So you'll hear them go, you know, and you try to keeping it in their mouth as long, and then they can swallow it, okay? So that thrush is, do you guys think that's just uncomfortable? That thrush, does that look like it would be uncomfortable? Yeah, right? So it's discomfort, burning of the mouth and throat, altered sense of taste. And it's more common in counts that drop below 100 in their CD4 counts. And we test it by scraping the sore and checking it under the microscope. So a lot of times we'll take that wooden blade and we'll scrape it and send it down to the lab. Now, if we have a systemic way to treat it is a fluconazole or diflucan, or another way we can do is clotrimazole. So there's a couple different fungal kind of medications that we can use for thrush, okay? All right, so symptomatic infection in that stage, you're gonna see shingles. Where have you guys, I know a couple of you guys have told me about, they've seen some shingles. Where have you guys seen shingles on a patient? It's that varicella zoster virus. Yeah, a lot of times the abdomen, the back, the first time I saw it was on the actually the first time I saw it was along the nerve line in your hair. So there's nerve tracks that'll follow the shingles. So the first patient I ever saw was a male who he didn't have a lot of hair. I think it was actually shaved, his head was shaved. And you could see where the shingles, the sores ran along his nerve tracks in his head. But the latest ones that you'll see is, and I know that some of you guys have seen that, like Jack Sparrow patients, where it was on their abdomen. So it looks like a really bright red, flaming, bubbly like rash. And depending on what stage of healing it is. Pain for the patient. Yeah, it's really painful. Went from abdomen round to her mid-back that Danielle saw. I think that a bunch of you guys saw her in Jack Sparrow. So yeah, shingles, you'll see persistent vaginal candidal infections, herpes, and bacterial infections. Yes, you guys saw the same patients. So it was bad. And you guys saw it kind of all at the same time. All right, the Kaposi's sarcoma. Has anybody watched? You guys need to watch them. What's the movie that I'm going to recommend you guys watch for HIV? Rent? Oh, was that? Oh, I'll have to look at that. Lauren, is there one? Is Rent show Kaposi's sarcoma? The other one, what's the movie with, I'll have to write that down and watch that movie. What's the one with Tom Hanks? Anybody seen Philadelphia, that movie? And that gives you an interesting picture of HIV, where it has Kaposi sarcoma. So it's they're malignant vascular lesions, such as they'll say KS lesions or Kaposi sarcoma, and they can appear anywhere on the skin surface or internal organs, and it's caused by the human herpes virus 8 in all the lesions, and they are very pinpoint to very large, and they are in a variety of different like healing modes. Remember with that patient yesterday when he injured himself, this is Kaposi sarcoma, they call them pepperoni spots, and you can see that they're in all different stages of healing. So this is a major sign of Kaposi sarcoma. And they can affect people following an organ transplant, and there are those purple lesions that you'll hear them sometimes called pepperoni spots. All right. Oral hair leukoplakia. So this is an Epstein-Barr virus infection that causes painless white raised lesions on the lateral aspect of the tongue and can occur at this phase of the infection, and is also an indicator of the disease progressing when we see this. Okay, it's benign and it's irremovable patch. So when you try to scrape it and send it down to the lab, it's not going to do like we did with the thrush where you can test for it. This one's not going to do that. Okay. All right. If we diagnosis of AIDS. So the immune system at this point is severely compromised. It's our greatest time for opportunistic diseases, possible malignancies, wasting, and dementia. All right. So how we classify AIDS is that it has to, the CDC, a diagnosis of AIDS cannot be made until the HIV infected patient meets criteria established by the CDC. So it's characterized by severe immune system suppression and CD4 count, T cell count less than 200. All right. An opportunistic infection, some of those that I've showed you, an opportunistic cancer, wasting syndrome, loss of 10% or more of the ideal body mass, or AIDS dementia complex. Okay. So those are the criteria that it has to meet. You'll also see this where we see it is a pneumocystic Carini or Girovetti is the middle word, pneumonia. So you'll see either PCP or PJP. And this opportunistic disease generally does not occur in the presence of a functioning immune system. And it is a type of pneumonia that appears as an opportunistic infection with HIV. In the early years of HIV, patients would get this, and 80% of them would die. It would be fatal if they got this. So they would use, what we do is we use sputum or tissue from the lungs to diagnose PCP or PJP. Okay.
Are they two different diseases, or
no,
are they
it's the same one? They just use two different terms for it. So you might see it PJP or PCP. That's a good question. Fungus commonly in the environment that we normally see in the environment that doesn't really affect us, but it would if we were diagnosed with HIV. Okay. All right, guys, we're gonna get through this HIV stuff. All right. So our diagnostic tests you guys are going to see are these ELISA test, and it stands for this enzyme linked immunoassay. And what happens is you're going to see, it's going to tell us that we're having antibodies in 2 to 4 weeks. The problem with this ELISA test is that it could be a false positive or a false negative, because this tells us we're having antibodies to fight something like HIV, but it might not be. We might have malaria or hepatitis. So the body's trying to attack something, but it's not specific to HIV. Okay, similar to other tests that we've talked about. So this one will tell us that our body's fighting fighting infection from something, but it's not specific to HIV. All right. So that's kind of the first one they'll use to see if they can get it back pretty quick. Now, the Western blot test is a confirmative diagnosis that we have HIV antibodies, that it's specific to antibodies. Okay. And all of these we use blood to test this. Okay. And then viral load test is what we're looking at during the treatment to see where our T cell counts are. Okay. All right. All right. And what we like to say is it might take a couple weeks, several weeks to detect the antibody. So those rapid HIV antibody tests can provide results before patients leave the office, but should be confirmed. Okay. So what you'll see is a lot of times we want to do this rapid test to tell us if they have that. But because we have them in the office, and we might not get them back if we can't tell them the results right away, because it can be somebody who doesn't necessarily, we don't have a good way to communicate with that patient. Okay. Or they don't have a stable housing or a phone that we can get a hold of. So rapid HIV antibody testing is a big thing that happens. Beneficial, as many do not return for follow-up. So you'll see that kind of being done to try to check to see if they have anything that we're concerned about. We have to monitor progression, immunofunction, manage symptoms, and initiate and monitor our ART, the antiretroviral therapy. Okay, and we are using it to prevent or treat opportunistic infections we need to do while this patient is in treatment for HIV or positive for HIV exposure. All right, so we have to gather our data. We want to establish a relationship with the patient, and we need to initiate teaching with the patient. All right, it gets tracked by the health department. Our main goals here with this patient is to decrease viral load, maintain increased CD4 count as best we can, prevent HIV-related symptoms and opportunistic disease, and then delay or disease progression with the drug therapy. All right, we have an acronym that we use here that's HEART therapy, and this HEART therapy is expensive and effective. So it's highly active antiretroviral therapy. So it stops the replication, but it doesn't kill the virus. So we're slowing it down with these drugs. So you'll see where, now you have some where we can get into where you guys have to memorize all the drugs. Well, I think that's not necessarily necessary in the sense that if you start working with this, then you're going to learn all these drugs. But you're going to see these are the different types of drugs you'll see with HIV. These nucleosides, non-nucleosides, and nucleotide reverse transcriptase inhibitors. So these are these are the categories of those drugs that you're going to do. Inhibit early replication. That's what these drugs do. These protease inhibitors interfere with the activity of the enzyme protease, and then fusion inhibitors interfere with the HIV CD4 receptor site binding and entry into cells. Okay. This next one is you're going to hear him talking about a cocktail. Okay. So it's basically we're combining antiretroviral therapy in 3 or more drugs from different groups. So we're trying to there's a video that I want you guys to watch, and it should be at the end of my slides here, where it tells you about how we've cured. There's been 2 males that we've cured of HIV. So, and we've done this by clipping the ladder, we call it, on that RNA where it can't enter into the cell to start killing the cells off. Okay. So, but the way that we treat these patients is we have a cocktail, and I like not the shrimp cocktail, but the drug cocktail. So they put 3 or more drugs together to confuse the virus, but the virus is very smart and can replicate, and the drugs, slow it down, but it's still surviving, right? So for instance, the latest drug that I've seen is Genvoya is the last drug that I've seen patient have recently taken. So when I tell you guys Genvoya, so it's Genvoya, and after the Genvoya, it says 150, comma, 150, comma, 200, comma, and 10, comma, or no comma after the 10. And then it says milligrams. So what is that telling me? It says 150, 150, 200, and 10. So how many drugs are in Genvoya, would you guys say? Yes. Yes. F. What are you doing to F? So yes, they're 4. Yes. Okay. You're making me laugh. Okay. Yes, 4 drugs. So they've combined 4 drugs into this one pill that this person's taking, because it used to be, and you'll see when that video, these people are having to take cups full of drugs to stop this disease when it first started. But now we've gotten really good at combining them where they only have to take 1 pill. Okay. Which is, awesome, because taking a pill every day can be hard, right? All right, so our thing that we have to do as nurses, we don't assume about, we don't make assumptions about who can be at risk, right? We screen everyone if we're going to do that. We want to have candid conversations, so truthful conversations, and it's important for having effective management of HIV, all right? And at-risk patients receiving blood transfusions or clotting factors before 1985, because after 1985, we've gotten really good at screening blood for that. Our goals at compliance with drug regime. So what do we use? Like we use my phone or I put my time in for when we need a break, right? So what can we do with the patients in regards to the phone to help them remind them to take their drugs? What do you think some of the technology we use? How do we do this? So we can set up like phone alarms like I do for the timing to help them remind them. Yep, good. Put reminders on our phone. We're going to talk to them about healthy lifestyles, adoption, exercise, adopting a healthy lifestyle, our food, relationships, beneficial relationships, spiritual well-being in regards to life and death, right? Because we've slowed it down, but have we cured it? But we have in these 2 cases. You guys are going to see this movie where in some cases we have, but these 2 gentlemen had specific things that they were able to identify, and they found these kind of things in research mice to help with cures towards this. Coping with the disease and treatment. So of course, prevention is always going to be, if we can stop this on the front end. So decreasing risks, sexual intercourse, abstinence, non-contact safe sex using barriers. You're going to hear about male and female condoms have 100% efficacy and then are more than 90% effective. So you'll see lots of education in schools and in the communities about abstinence, faithfulness, condoms. A big thing in other countries, if we don't have the education in our country and other countries, I can't just say other countries, is you have to have that education piece, and they have to know why this is happening, right? All right, so decreasing risk at work, adhere to precautions and safety measures to avoid exposure. So if we have nurses that don't use their, safety needles or don't report exposures for timely treatment and counseling, right? If we have a problem, we need to know. If a bunch of nurses are all of a sudden getting stuck by these needles, we're like, what's happening? And then post-exposure prophylaxis and combination of ART can significantly decrease the risk of the infection. And then testing is the only sure method of determining HIV infection. So we've seen that with COVID also, that we need to test and find out. CDC recommends universal voluntary testing for everyone ages 13 to 64, and an estimated 21% of people living with HIV are not aware they're infected. Okay. And then when do we start it? So the problem is that antiretroviral therapy, it has lots of side effects. It can be complex with our scheduling. And what we have to do is we have to make sure the patient's ready is the most important thing. And then we want to avoid burnout and non-adherence. So treatment is recommended when the immune suppression is the greatest. So we have to see what stage they're in, when is the best time. So we're going to work with everyone individually on that. All right, so our drug regimen, we want to prevent that disease progression, opportunistic, all those diseases that can happen, and then viral drug resistance, and an individualized approach is the best for it. So we've gone to those one pill, we've gone to those phone reminders, we've helped educate the families about it. We know that it has no cure, it continues for life, and can cause some physical disabilities along the way. And we have to have them, so we want to help them socially, emotionally, economically, and spiritually. And ultimately, it will lead to death. All right, we also have that stigma that goes along with it that can cause social isolation, dependency. So that's why we've created in public health, we have, you'll see HIV clinics, and they might have morphed with that adult health clinic, but you'll even see them where they come in and meet regularly with a physician who's actually in that clinic, and they follow those particular patients. And then with this HIV going on, then it could even involve riskier behavior because of all this that's going on with the social isolation and the low self-image and everything. Common problems, this is what we're going to see. Side effects, the nausea, vomiting, fatigue, the pain, diarrhea, the peripheral neuropathy will happen. All right. And then certain metabolic disorders can cause, so they can get these other things along with it as they're getting sicker, and can cause other problems with them. Lipodystrophy, that's the lipodystrophy, I'm gonna say it right. This will happen where this body, so basically they have changes in their body shape. So their fat deposits in their abdomen, their upper back, and their breasts, and they have fat loss in arms, legs, and face. And it can manifest as a buffalo hump or facial wasting, you'll see, which is in conjunction with these metabolic disorders that can happen along with this. And what will happen is if we start getting this, we're going to possibly change our art therapy, the medication therapy. Okay. All right. Again, we're going to deal with comfort, accepting what's going on, help him work, get some counseling. All right, so here is the videos I'd like you guys to watch. So this is the one, it's 20 minutes, the first man to be cured of HIV. And this is a 28-minute video that's really good, that is put out by the CDC about HIV and what all is going on, and kind of giving you kind of a review of what we just went over. Okay, they're both really good, so I'd like you guys to watch those. All right, how you guys doing? You need another 5-minute break, or are we okay? Okay. Anybody else? Everyone okay? All right. Like either way. All right. Well, we can look at this. Let me see how many questions I have here, guys. All right. You guys want to do these? Then there's a case study in here. So you guys can look at those questions. I'll let you guys look at those questions on your own. And then we're going to move on to cancer and do a little of the cancer. Okay. All right. And then this, you guys can look at this, and you can look at these questions. This one's pretty short, and look at those questions and see if they match up. And it kind of goes through the stages, but I kind of like the diagrams and everything better to show you. All right. Okay, let's go to this one. So I'll reassign all those, and we're going to go to this one right here. The chapter 15 one. All right, I'll give you guys a minute. All right, let's talk about cancer for our last section here. Things I like to focus on. All right, so here's some quotes that I thought were good for cancer, in relation to cancer. Once we kind of get into this, cancer growth for the sake of growth is the ideology of cancer cell. And jealousy is a mental cancer, and don't give up, don't ever give up. So at the end of this video is a talk by this Jimmy Valvano. Does anybody know Jimmy Valvano? See if anyone knows him. No. Anybody? No. Anybody else out there know him? I think he was a basketball coach, and he was actually diagnosed with cancer, and he does a little speech, and it's really good. So I have the others. I'm like, is anybody there? Anybody? We have 41 on. All right. So if you guys look at this, we know that with cancer, we start seeing a defective cellular differentiation and defective cellular proliferation. So you guys remember the cell cycle, right? Where you have mitosis and you have the cell developing and regenerating and growth of new cells as we go with our body, right? That happens all the time. So what we're going to do, what happens with these cells are the cancer cells grow at the same rate of normal cells, but might produce 2 cells instead of the 1. So it's a malfunction in the gene that happens. So it's uncontrolled, it's unregulated growth of cells that are happening. So, and we know, what did the cells start from? What's that cell that they start from? New cells start from what type of cell did we say? Right, stem cells. So, and then they start producing. So with benign, they're growing slow. And then when we have cell death, we have new cells that develop, or with cancer, they degenerate basically, okay? So if you're looking at benign versus malignant, so here are different characteristics, and you guys can compare them here. So if we're looking at the benign, or the slow growing side of it, that's the better one, right? With encapsulation, it's usually encapsulated, and I'm going to show you guys some pictures of that. With a malignant tumor, that's rare, okay? So a lot of times it has infiltrated fingers with that malignant one, right? Differentiated, which is with a benign one, it's partially, and with a malignant tumor, it's poorly. With metastasis or spreading, it's usually absent with the benign tumor, but frequently present with our malignant one. And then recurring, it usually doesn't, it's rare to recur if you have a benign tumor, but with a malignant tumor, it frequently reoccurs. With vascularity, and we have slight ones in benign tumor, but moderate and marked ones in that circulation that's happening. The mode of growth is usually slow growing or expansive, and the one with a malignant is infiltrative and expansive, okay? So, and then cell characteristics, which if you guys slide this down, cell characteristics are kind of the most important for that. So for benign, it's usually normal cells and very similar to that parent cell, so that original cell. Whereas with malignant ones, they're abnormal and unlike the parent cell, okay? And that's what that says on the bottom there. So with tumors, you need to understand those differences between the benign and malignant, right? OMA stands for tumor, cancer. It's added to the affected body part. So you're going to hear us categorize different cancers like that. So if we look at the next one here. So we have this theoretical model of these 4 phases of initiation for cancer development. So we have this initiation, promotion, progression, and metastasis. So if you look here, we know that the #1 role of our immune system is to do what in relation to cancer development? What are we trying to do with our immune system in relation to cancer? We're trying to fight it, right? So we're fighting off the cancer, and if my immune system is incompetent, I'm not able to do that, right? All right, so you're going to see classifications of cancer. It can be either by anatomical, it can be by histological analysis or grading, or the extent of the disease or staging, okay? And we'll see, I'll look at that. So what you're going to see by anatomical here, this is the first thing, is you're going to see embryonal tumors or mesenchyme. You'll hear mesenchyme is another term used for embryonal tumors, and then that arises from the embryonic tissue. Okay. Lymphomas arise from that lymph system. Leukemias arise from blood-forming organs, problem with your blood or your bone marrow biopsies. Sarcomas are derived from connective and supportive tissue. Carcinomas derived from epithelial tissue. And then adenocarcinomas derived from those granular tissues or those secretion tissues, right? All right, so we look at this grading, and so we can do grading, which is the histological analysis amount of differentiation. So the cellular differentiation, you're going to see it graded from 1 to 4 on this, and you see this 1 to 4. So the best is 1, where it's sick and healthy cells. Grade 2 is going to be moderate abnormal cells. Grade 3 is going to be abnormal cells, and grade 4 is going to be immature cell of origin and difficult to determine. So that's on the grading side. The staging is 0 to 4. So that is the extent of the disease, the amount of proliferation, and then it's 0 to 4. So what we say is 0 would be our best. It would be a carcinoma in situ, we call it, where it's inside, there's no mass per se, and it's like in that same place. And then number 1 is a localized tumor growth, which is less than 2 centimeters. And then 2 is local spread, 3 is regional spread, and 4 is metastasis, where it's spread out. So 1 is the least, 4 is the worst. So when they say, okay, he's in stage 4 cancer, we know that's the worst stage, okay? So what you'll see is they'll also do where they'll do, okay, if we do 1, we're in stage 1, no lymph nodes involved, no metastasis, and it's less than 2 centimeters. The 2 is that local lymph node, when I said localized tumor growth. The local lymph nodes can be involved, no metastasis less than 5 centimeters. So they use 2 centimeters, 5 centimeters, or greater than 5 centimeters. So they can have nodal involvement, no metastasis, nodal involvement, metastasis, and then it's greater than 5 centimeters, which is greater than 2 inches if you compare it to inches, because there's 2.5 centimeters and an inch, right? All right, so if we look at this, this is the thing you're going to see where they're going to do the staging and tell you where the tumor is. So you're going to see them do the International Union Against Cancer and the American Joint Commission on Cancer got together and created a new staging classification system called TNM. Okay. So T is the primary tumor, and you guys can see where it's writing out the stages. So T0, no evidence of primary tumor. And then the T1S is that carcinoma in situ, where it's stayed in that local area and it's kind of capsulated together. And then T1 through 4, ascending degrees of increase in tumor size and involvement. So that's talking about the tumor. The regional lymph nodes is the N, so nodes is the N. So again, no evidence of disease in lymph nodes, ascending degrees of nodal involvement, and then regional lymph nodes unable to be clinically assessed. So TNM is going to tell us the tumor, the nodes, the lymph nodes, and then the metastasis, and how the M is the metastasis and how it's spread. Okay. It's a uniform system used worldwide for describing the anatomic extent of most solid tumors. Okay. All right. So what happens a lot of times is you're going to see we have this patient started off with testicular cancer, and then he had a metastasis of a lesion. So we see, we used our ruler, right? So that can tell us kind of how big that is in regards to us using that ruler, like we like to. And this was So he had a primary testicular cancer, and then he had this lesion on his head that he got, which would be considered a skin cancer on his head. Okay. Lung cancer, and you're going to see certain cancers metastasize to certain areas. Okay, so very common for this particular one to have the skin cancer. Another one you're going to see is lung cancer to, like an example would be lung cancer. A lot of times that can spread. The metastasis happens to the liver and the bone. Okay. All right, so different prevention. We're always going to talk about prevention because that's our goal to do that. We like to use this acronym called the 7 warning signs of cancer. So if you guys look at this, and I'll copy this, I also have another one. And if you have those memory sheets, this form is called Caution Early Warning Signs, and it uses the caution also. So I can scan this in, but it says the same stuff over here. So C is that change in bowel or bladder habits. All right, so with that, you're going to see ribbon-like stools sometimes you'll see with a cancer patient. We call that is a sign. So you'll see blood in their stool, ribbon-like stools, and a mass that's causing that. Okay, so that's coming off that mass. A sore that doesn't heal, that's a big skin. A lesion that doesn't heal is a big one. So a lot of times people will get lesions like on their nose, for instance, where the scabs up, and then you're like, okay, the scab, they take the scab away, say they pick at the scab, but then it never heals though, it keeps coming. So that's a sign of skin cancer. Okay. Unusual bleeding or discharge. We'll see that. Thickening or lump for the T. Indigestion or difficulty swallowing. What in particular cancer do you guys think that's coming from? What type of cancer are they having if they're thickening, an indigestion or difficulty swallowing? Throat, esophageal, yeah, in that area. And then continuous change in wart or mold. So we look at different, another thing, I'll scan this one too. Skin cancer is a big one we like to do. And there's the ABCDEs of melanoma. So I have a little chart for you guys that I can show you here. So that has asymmetry is a big one, that if it's not symmetric, that we have an issue there. Border, an irregular, scalloped, or poorly defined border. Color, so we know if we have those kind of like that pepperoni those pepperoni spots where they're in different, varied from one area to another, shades of tan, brown, black, and sometimes white, red, or blue. And then diameter, like for a melanoma, which is is the deadliest type of skin cancer, it's usually greater than 6 millimeters, bigger than the size of a pencil eraser when diagnosed, and they can be smaller, but a lot of times they're bigger than that. And then a mole or skin lesion that looks different from the rest or is changing in size, shape, or color. All right, so there's some signs for that. So, and that's what they're talking about, obvious changes in wart or mole, and then a nagging cough or hoarseness. So these are some of the ones which again will be like laryngeal or throat, something that's going on that. So our different prevention, we talk about avoid carcinogens. What's our big carcinogen that we talked about in respiratory that we want to stay away from? What's the biggest one that's causing those lung cancers? Yep. Cigarettes. You'll also hear them talking about asbestos, if someone was exposed to asbestos. Balanced diet, exercise regularly, sleep 6 to 8 hours, have regular health exams, and decrease stress. So live a healthy lifestyle. Food preservatives are another one that we're always looking at. Genetic tendencies, so family history of other cancers. We're going to talk about that because we'll test. People will get, if for instance your dad had a colon cancer, we're going to maybe doing screening earlier on you because of that. Okay. And then age of 40, we know, for that test for blood in the stools. And then, we'll look for that. There was a situation where they were running a health fair. I like to tell you guys this example where they were coming in, and getting blood work just done. And we were just running like a CBC, and for guys, we would add a test or a PSA to check for prostate cancer at a certain age. So depending on what age they were. So, and a lot of times those health fairs that they run, we're looking for just a CBC, and we're checking their cholesterol levels, because these are a lot of times high risk people that don't want to come in and don't get regular exams, and don't want to, just don't come in as often as maybe they should. So we had a situation where we were running a health fair, and the lab came and said, hey, we have a critical value of a hemoglobin on a patient that came in from the health fair. And I'm like, I'm like, what? Because critical values are usually people who are in the hospital. So I was like, oh, geez, okay, who is it? And they're like, well, it's this person. They tell me the name, and I'm like, all right, do we have a number on them? Or so we looked at the relatives, and we knew one of the relatives. So we called her and said, hey, we need your relative to come in and get tested because they have a critical value and something's going on. Well, come to find out, he had a really low hemoglobin, and he ended up having colon cancer, and we just caught it in a regular health fair. All right, so stuff like that. Even we'll do that a lot. That will happen with those prostate, where we will get high results, and just by they just came into a regular health fair, just happened to come with a relative, and we've had some of those cases happen, and just in the local area. So, so some of that comes up. All right, so you're gonna see. How are we doing, you guys? All right, is everybody hanging in there? Can you guys last for about a couple more minutes? Everyone okay? Anybody there? Let's see. Yes, okay. All right, guys, so you're gonna see different ways to detect cancer. So you're gonna see for women pap smears, we're gonna look for changes in the cells that we're looking for on those pap smears. That's why we do those, looking for cervical cancer with that. Chest x-rays, so we're looking for masses with those chest x-rays. We do CBCs, so we're looking at that WBCs, those differentials with blood. The proctoscope exam, so we're looking at that rectum, we're looking to see if we have any kind of tumors. Liver function exams, we're looking for the hepatic cellular carcinomas with that. MRI, CT scans, looking for different masses. Mammograms for women and men, right? We've had where we have men that'll have tumors like that, and sometimes ignore them. Let me see. There's a doctor in Fort Worth, and he wrote a book about how he was a surgeon, and he had a tumor in his breast, and he just ignored it until he was water skiing on the lake, on Possum Kingdom Lake, and his daughter was like, oh my gosh, what is that? And he kept ignoring it. So the only way in this story to definitively tell you if it's cancer or not is to have a biopsy. All right, so you guys know that. So what he did was he biopsied the tumor himself after he ignored it for 3 months, and took it down to the lab, and of course knew the people, because the pathologist is the person who would test to see if it's cancer. He just gave the sample to the pathologist, didn't tell the pathologist it was him that he was testing, and the pathologist was like, hey, this is malignant cancer, this is malignant breast cancer. And as soon as the pathologist gave him that report, just as a friend, thinking it was one of his patients, he saw his face, and he's like, oh my gosh, this is your sample. And he's like, yeah. So, he writes about this in his book. So it's not just women, it's men also, right? That'll have, that we have to screen for this. All right. Radioisotopes, which is nuclear medicine. Sometimes we've talked about using nuclear medicine for the heart, where we do stress tests. They will also look for cancers with that. And then lymph angiography. So of course, those are those lymph nodes that we're looking at and seeing if there's any kind of spread going on through that. You're going to see these oncofecal antigens, they're called. So they're testing for different markers for these cancers. So The CEA is for breast cancer. All right. The AFP is called alpha-1 fetal proteins. And that is for substances produced by, so what these are, these fecal antigens are, they're substances produced by that tumor that are leaking out into the blood. So we can look for liver cell cancer from the AFP, and the POA is the pancreatic. So we can test for those using these different markers, right? Who do we talk about? CEA, where they look at those markers when they know they're, like, for instance, with the breast cancer, they know that like a family member, mother, sister, all those have breast cancer, and then they start doing those surgeries, right? Where they remove both breasts, the uterus, anywhere where they could get that cancer. So you have to make an individual decision, right, when you get these tests back, because it doesn't necessarily mean you're you're gonna have it for sure. You might have some markers for that, but then they have to kind of decide how they're going to go with that. It's interesting to see where you have breast cancer. A lot of times they'll take off one breast, right? But then you have a woman who's left the other breast. Now the worry with that is that they're going to have to keep testing to look for cancer that develops on the other side, right? So then they're going to have mammograms every year to follow up on that, or however often they want them to have because of their risk. So now you have women in debates of whether they're going to take both, because the stress of having to redo that mammogram and test every year to follow up to see if you're going to lose the other one can be so stressful that women decide to take both of them. Does that make sense? So it's it's kind of interesting how that all comes about. All right. And then, you have a lot of times with the breast cancer, and they have mastectomies where they get both breasts removed or one breast removed. That's when you'll see the most JPs that you'll work with. A lot of times they'll have 4 JPs, 2 on each side, and you'll be pinning those inside the patient's gown. You'll be using your alcohol to like strip them. I know some of you guys worked with the neurologist who had JPs in the back in the spinal cord, but the most JPs you'll work with are those breast cancer patients. Okay. And then they'll usually take 2 out and they'll leave 2. And then maybe a week or 2, they'll take the last 2 out, where you might have to clip the stitches and kind of pull that out. All right. And then we know biopsy, bone marrow, exam, lumbar punctures to see if we have any kind of cancer in our bones, or it's what's happening with our cells. So, but biopsy is our only way we can detect that for sure. All right. So we have different treatments. We know we have surgery, radiation, chemo. We have this biotherapy, immune therapy, and we have bone marrow transplant. So our goals for therapy could be cure, could be control, or can be palliation, or relief of pain or whatever symptoms they're having with that. We provide that pain control. We give them the best quality of life that we can. A lot of times you're going to see what we call multifaceted or multinodal combinations of treatments. Radiation makes you extremely fatigued, and any kind of these treatments, we have to get consent and inform them of what's the prognosis and what's going to happen. Okay. All right. We also see complementary alternative therapy with these. So the statistic, kind of the latest, this was actually in 2001, so it's a little old, but it says 56.3% of gynecological patients with cancer use alternative therapies, and only about 31% of those physicians know they're doing that. Okay, so they're using other kind of things. You're going to hear alternative therapies like acupuncture and acupressure, homeopathic medications, meditation, yoga, aromatherapy, herbal medicines, and then they'll go to other countries, right, sometimes, and get treatments for that to alleviate the symptoms. So the big thing that we want to talk to patients about with those alternative therapies are the US pharmacy notations. Natural doesn't always mean safe, right? And then naturally known food and drug manufacturers, we want them to be, you know, evidence-based before people are doing these and request information. You want to teach them to request that information about the condition which that product was made for, you know, because some of these things are secondary features of these drugs and other things. So a lot of times people will go to Mexico and Texas outside, and we always are like, okay, has there been a lot of research on that? And then drug interactions are a large concern that we have with these alternative therapies. All right, so location of the tumor, it can be characterized by that, the size, the growth, our resistance cells, and the rate of sensitivity, and the degree of heterogeneity is how you say it. So it refers to the difference among individual cells within the tumor. So these differences increase as the tumor grows because of the random mutation that's happening as the tumor progresses. So basically, the tumor can become highly resistant to any one specific therapy. Okay, so that's why we have to do different types of therapy, just like kind of that HIV thing. We have to do different types of drugs. Same thing with the cancer because of the genetic composition, invasiveness, growth, hormonal responsiveness, metastatic potential of spreading, and susceptibility to anti-neoplastic drugs. Okay, so yeah, it can be tricky also. All right, so we're going to show some pictures. So they're kind of graphic. So this is an encapsulated. So it's all within. It does a good job. The tumor is self-contained basically, and we call it encapsulated. But this is a large tumor, but it's a good thing when it's all together and we can get it out pretty easy. Okay, that's our goal. And again, we're using our ruler, which I like to point out so we can kind of see how big it is. Here is a non-encapsulated infiltrative tumor. Where is this? What are you guys looking at right here? What organ are we looking at here where this tumor has grown all around it? You've seen, yeah, intestines, exactly, you guys, yeah. So this photo example, non-encapsulated tumor removed from the colon cancer, more difficult to surgically remove, usually requires additional treatments in the form of radiation and chemo, okay? All right, so look at this one. So this is oral cancer. So this was an 18-year-old female, and her tumor looked pretty encapsulated and localized, and it was the dentist who found this tumor, right? Okay, so the next picture is graphic. So if you don't want to look at that, it's fine. Okay, so we thought this was encapsulated. It looks like it was encapsulated, but once they went into surgery, it was not. Okay, so it was infiltrated mouth cancer all over, and it was just really extensive. And so that's sometimes when they get in for surgery, it's a lot worse than they thought. Okay. After her surgery, this is how she looked. So this is the same girl post-op. Despite how extensive her surgery was, they were able to approximate her facial flap for good healing. And this was a patient that was in Houston.
Professor Hall?
Yes, ma'am.
Can you go back 2 slides or 3 slides on that one? The beginning of it. Okay. Is it this far left corner on this, or her far right side where you got your mouse moving? Is that where that is?
Yeah, it's right here.
Okay.
See where it's right here?
Yeah.
See where it's outlined? So it looks like it's all in that one area, right? Where it's all, but then once they opened her face, it was all throughout that. So they had to remove all that. So, and sometimes they like to do it all in one surgery, right? But sometimes, sometimes if they'll do the surgery, get as much as they can, and then they're going to do radiation chemo, and they might have to do another surgery. So, but with this girl, they just did the one and got, most of it out. So, sorry guys, if you don't like to see that. All right. Okay, guys, we're going to do 5 more. Let's talk about radiation. So what you'll see is you're going to see external radiation and internal seeded and unseeded. So basically from this one, we receive rays from the machine. This is a cobalt machine up here. So you can see where the rays come from, and it's scattered rays, and the healthcare worker has to wear lead to go into that room. Okay. So, and then internal seated is when we talk about radioactive material that's entered into the body cavity. Okay. Free radicals, DNA, RNA, enzymes of the cells are what we're trying to take care of. Okay. So the head of that machine. So if we look at this one, this is a safer one because the radiation scatter is behind this patient. It's not in the same room as that person is. Okay. This is a linear accelerator, we call it. More commonly used today because the radiation is located behind the machine, preventing the rads from scattering all over the room like they do with the cobalt. So it's a safer. So it'll be interesting for you guys to know which type of machine you have at your facility. If you go down and take a patient, a lot of times you're not going to see the healthcare worker. They're going to set them up in that room, but they're going to leave the room, right? And be in the booth to shoot the pictures. Okay. Now nowadays we have, this is old style where it's permanent dye markers. So that radiation is going to be shot where those X's are on that patient. Now it was important for us not to wash this patient when they were in the middle of therapy. So you didn't want to mark off those X marks, but we don't see that as much. But I wanted to show you guys how they used to do that. Okay, so now what you're going to see, I have an example of one, is you're going to see where they do this mesh. So this looks like a head, right? So this was a patient's where they have. So they put this over the patient in for radiation, and they'll mark on it with the diameters of where they're going to do this once they put this over. So the patient can lay there and they can breathe through that, right? Because it's a mesh. And then these are the marks where they're going to radiate that patient instead of doing this old school with ink. Okay, where we have to be sure that it doesn't get washed off and all that kind of stuff. Now they do this, is how they do it. Has anybody seen anything like this? Where they shoot the radiation and create a mole. Basically, this is a plastic mole that forms around them, and every time they do the treatment, they put this over them and they know where their markings are. Okay, and they keep that at the radiation center and then give it once the person's done. All right. So we know that radiation is silent, it's invisible and painless. A lot of times the patient complains of the table being hard, so it's pain from the table. And when the machine's off, the radiation is no longer being emitted. Okay, so if the machine's off, then you're fine. It's when the machine's going. So with radiation, you're going to hear about radiation burns. So you're going to see ulcers, sloughing. So you're going to see this redness. You can see swelling and inflammation. We want to reduce the friction, no irritation, sun or chemicals. So we want to get them patients when they're going through this. We want to, my mom had that breakdown in the air. Oh, I know, it's sad. So you don't want sun or chemicals. The patients, of course, can lose their hair. And the big thing is permanent sterility. So before they have these cancer treatments, this radiation and chemo, a lot of times if they're a younger person who still wants to have kids, we freeze their eggs or sperm, depending on if it's a male or female. And then their patients after radiation are going to be extremely fatigued. All right, sleeping lots. So skincare wise, we want to handle areas with care and be gentle. We want these patients to wear loose fitting clothes, avoid deodorants, and then we really want them to stay out of the sun. Okay. All right, you guys, let's do one more here. I think I'm also, yeah, we actually, let's, you know what, let's stop here. We're going to stop here, you guys, and we'll finish up this part for this so I can show you these different things. All right, you guys have any questions? How's everyone hanging out?
Professor Hall,
Yes,
okay.
yes, ma'am.
I did not know, but you're saying, I mean, I heard you at the beginning, but I didn't realize what time it was during the month.
Okay.
But next week we don't have class.
Correct.
So whatever other chapters that we're supposed to go over today, or was 35, 36, and 15 the only ones that you were going to cover?
So if there's something else in those other chapters, because those other chapters were like allergic reactions and some
Like 36, 30, 35, 36, 37, and 38, I think it was.
So 35 and 36 are for sure. And then 15, which is the cancer. Cancer is 15. 35 is the immune system, and 36 is where the HIV and that is in. And then the other two are kind of newer chapters. So if there's something that I want you guys to know in those chapters, I'm going to do another recording of that. So the rest of this I'll tie into there, and then any other areas that I want you to know, and I'll tell you, hey, this is in this chapter or that chapter. Okay.
You'll post it to either D2L or
yeah, I'll put it in D2L. I'll put it in.
Okay.
I'll post in detail and let you know, and I might post it in Top Hat and D2L depending on what all goes with it, because I know a lot of people are having issues with the computer and stuff.
Okay. All right. I just wanted to make sure.
No, good question. Sounds good. You're welcome. You guys have a nice weekend. Study hard. Do we already have a PEDS test on Tuesday? Is that why she's making our PEDS test, right?
No, thankfully. I thought we did too.
Okay. I was like, so it's the 9th, right? No, wait, hold on. When is yours? When is it?
It is.
When is your next one? The 6th. So it's after Easter, right? Your third one for her.
Yeah.
Okay.
I was going to ask, what days are we off again?
So you guys are off. Your break starts at, and you guys can tell me if I'm right or wrong, but this is how I've written down. The 31st at 10 p.m. is the break starts that Wednesday night. So you guys will be off the 1st, 2nd, 3rd, and 4th.
Oh, wow. Okay, thank you.
Yeah, it's like a mini Easter break, thank goodness, huh?
Yeah, sure.
Scared about the PEDS exam. Okay. No, don't be scared about it. She said it's going to be really easy. I don't know. I know she was working on it. All right. You guys enjoy your weekend. We'll see you guys next week.
Yes, ma'am. At least we get a few days off since we didn't get a spring break.
Exactly. You guys are going to be out early by the end of April. It seems like it's going fast.
Yes. Thank you.
You're welcome.